Hello, hello. Audiences, can you hear me? Hello? Midda, Ankur Midda. Dr. Ankur Midda, can you hear me in the OT?
Sir, you are audible.
Hello? Dr. Midda? Hello, audiovisual team?
Yes, you are audible.
Hello? Hello? Dr. Midda? Doc- Dr. Sinha, Dr. Ankur Sinha, can you hear me?
So I'm Dr. Ankur. Just Dr. Sinha is getting ready.
अरे भाई मेरा माइक नहीं चलता क्या?
So,
Hello?
Yes, sir.
am I
you are
audible?
Yeah.
So,
So can you detail some regarding your surgery? Hello?
Sir, this is planning for MIGS case. So we are just operating the cataract. And now Dr. Ankur Sinha will take off and he will be performing MIGS surgery for our symposium.
mute कैसे होगा?
Hello. Hello.
Hello, yes. Can we get some audio input from the OT? Dr. Ankur?
So, hello, is it audible from the OT?
Yeah, it's audible, but can you just
Yeah,
increase the audio?
I would just appreciate Dr. Mayank having done the surgery so beautifully in such a small pupil. The way he has handled the iris is worth a real applause from all the audience. In the beginning, when he actually started, it appeared that the iris would prolapse and my heart was sinking. But the way he has handled, he did the rexes and the nucleotomy and now the IA. I believe every stop is worth an applause, and doing such a surgery in such a small pupil is really commendable.
So, was this surgery planned this way?
Sir, this is for MIGS.
Okay.
No, but I just mean to say, though it was planned for an mix, but the way he did a phaco is beautiful.
हमारा IL ही फंस गया इसमें, क्या बकवास है? इसको ले.
Dr. Mayank,
Yes, sir.
have you preoperatively assessed this case of IFIS or non-dilating pupil?
Yes, sir. We had diagnosed, and we just planned it for this combined phaco with MIGS. So this is basically a patient who will be benefited from MIGS procedure.
So for such kind of small pupil, have you not prepared for the rings and pupil expanding devices?
Sir, I was not planning that, but he just planned it right now. Only this case was selected for this, and had I found this difficult, not getting operated, so I would have planned a pupil expansion, iris hooks, anything else. But I was able to complete it, so I just planned it. Okay, it will be that. We have blocked the case already, so it's under LA only. So things could have been modified accordingly.
Okay.
The way you handled the small pupil and without the rings or any pupil expander, I think if your skill set and your confidence gives you that kind of ability to handle this, why will you actually require the pupil expanders? So that is the way to do. And
Yes,
if a surgeon is confident, then he does not need those extra instruments to actually pull the pupil apart and cause extra trauma to the eye and enlarge the surgical procedure, sir.
Okay. Okay.
नहीं करूँगा सर. बस IOL डाल रहा हूँ. पाइलो डाल. हाँ IOL डाल. IOL डाल के पाइलो डाल.
Dr. Mayank,
Yes, sir.
have you used some intracameral this Medrican or Ultra T plus Ultra or anything in this?
Yes, sir. I tried. I had put Phenocaine initially, and Ankur sir is behind me. He's saying dilate नहीं करना है, नहीं करना है.
Okay.
Linsky.
Very nicely done. This was, I think, without dilating the pupil. The pupil was not dilated pre-operatively, and neither any intracameral epitrate or anything was used, and it has been very nicely done.
Now dilating as well as atonic and fluffy iris also.
But as far as the message to the audience is concerned, it is just that because this case was planned for MIGS, it has been done without dilating. But otherwise, we don't recommend that any case should be done like this. We have got very good pupil expander. We can chemically expand the pupil. Otherwise, we can mechanically expand the pupil. Dr. Ankur?
Yes, Dr.
Can you
Ankur
just
Sinha will
brief
take
about-
over now.
Can you
Yes.
just brief about the pre-op IOP and the medication the patient was on?
Just Dr. Ankur Sinha will take over now, and he'll be explaining you the procedure. So.
So we had to make him pseudophakic. So we'll be just, बाबा जी उस तरफ गर्दन घुमाएंगे और घुमाएंगे थोड़ा सा और घुमाएंगे बस. So we are going to tilt the head away from us. Also rotate the microscope. थोड़ा सा और करेंगे उस तरफ. बस गर्दन उस तरफ रखनी है अपने को, है ना. लाइट में नहीं देखना है, उसी तरफ देखना है. So there are certain things here. इसको नीचे करना है भाई, नीचे करना है इसको.
This is a known
Mike,
case
उसको नीचे
of
करना है. हाँ.
glaucoma, and under I
थोड़ा
think
सा-
2 drugs.
थोड़ा सा ऊपर, हल्का सा नीचे. किधर से हो रहा है तेरा नीचे?
What was the pre-operative IOP?
नहीं नहीं, इतना नीचे
status?
नहीं, बस
What was the pre-operative IOP status?
Now it's under control. I think it's 19
Needle में बनाऊंगा।
written in the record.
19.
एक मिनट, एक बार माइक्रोस्कोप सेट करा दो यार।
So Dr. Sinha is adjusting his microscope, and he'll be telling you the microscope settings now.
So we need to up the table. टेबल ऊंची करनी है। टेबल वाला दे दो मेरे को एक बार।
Over to Dr. Ankur Sinha now.
So I have been told that the patient had a shallow AC, moderate glaucoma. I think there was a slide prepared. Can somebody share the slide? We're trying to focus, and then, so this is the post-surgery. We have tilted the eye nasally.
Can you just briefly tell us that for MIGS, what is
Just a
the
moment.
usual level of glaucoma?
So I have tilted the head of the patient away from us by a factor of around 35 to 40 degrees. Tilted the microscope away from us around 35 to 40 degrees. So this is how it looks like. Just adjusting my IPD. So
Can we just have the pre-operative sheet once again that was shown?
heal on GV देना. So we are going to air निकाल दिया.
Hello, are we audible from the hall? Hello, Dr. Ankur.
Yeah, yes sir. You are audible, but
Can you just ask someone to just show that pre-operative screen for a second, because we couldn't.
So we are going to overfill the antechamber with heal on GV.
Okay.
So there are some air bubbles. I think I need to take them out. Oh. So that widens the angle. Lens छोटा वाला दे दो. तुमने powdered पहने हैं? So मेरे पास तो है नहीं बॉस. वो अच्छा अंकुर मिड्डा. Okay. So then we have put this small saline देना एक बार. Small self-retaining Catena's hands-free IOL, hands-free gonioscopic lens. So this is the angle we can see. So can the angle be seen now?
Yes.
Yeah.
Yeah, it is visible.
So we can see there is some blood in the Schnemm's canal. If you can appreciate, there is a small hemorrhage here, and then there is a blood in the Schlemm's canal. The trabecular meshwork is pretty pigmented. Simple नहीं ये नहीं जो अपनी 5 ml needle syringe के साथ जो needle आती है 24 gauge. So we can see the angles pretty well. I'm just removing the lens, and I'll एक बार मुझे वो देना. नहीं ये नहीं. इसके साथ तो लगा 1 ml syringe में लगा दे इसको बेटे. And मुझे कोई ये देना. I need to see these side ports. Mayank, did you make 2 side ports or 1 side port? This is the 1 side port you have made. You have not made this side port. Okay. Now let us see. जरूरत होगी तो बना लेंगे. एक CV. So I'll just. So this is the needle which we are using. It's a 24 gauge needle. I hope it can be seen in the. ये ना CV देना बेटा ये तो खराब हो जाएगा. It's stronger. So let me take the table little down. So this is the needle, a normal 24 gauge needle which comes with any syringe. Visco कहाँ है? हाँ कॉर्निया पे डाल दे यार एकदम. कॉर्निया ड्राई नहीं हो जाएगा. बस. That's it. So we will be bending this needle. So this is the hub. We will be bending it here, and we'll bend it little like this, somewhere around 45 degrees. So this becomes a cutting thing for us, and then we again go back to the angles. Now this needs a little support from the other hand.
Hello, please center the picture. Sometimes it's going out of the field.
Yes, ma'am.
It's not focused now.
This gets focused.
Yeah, yeah.
Yeah.
And this is the main port from which we will go in.
Yeah, yeah.
We'll further zoom it. And we are going to enter the trabecular meshwork here.
Ankur sir, can you tell the OT people to switch off the light overhead you because it's causing a reflection over the area you're working on?
So I have entered the trabecular meshwork. So we are cutting the trabecular meshwork now. So we can see the opening here. Can you see this opening here?
Yes, yes.
This is opened and this is still not opened. So ideally we should be opening at the anterior margin of the trabecular meshwork. So we can see opening of the Schlimm's canal. Although there's not much of a bleed, I thought there's a blood in the Schlimm's canal, it will bleed, but it has not bled much. That's good, in fact, for the clarity of surgery.
Ankur sir,
Yes.
thoda center kariye please.
So now is it okay?
Yep. Yes.
So from here to here, so we can see this ridge here. This is the opened trabecular meshwork and the Schlimm's canal. So we've done almost 70 degrees of it. We can probably extend a little bit on this side. It is said that the most of the collector channels are nasally. So it is to be done in the nasal area for the best results for the control of IOP.
So routinely you do 70 to 80 degrees of.
Yeah, that's the routine thing. So you can see this white mark here. This is the opening, right? Can you see that?
Yes.
Yeah, yes.
So that's the opening of the Schlimm's canal, deroofing of it. And good that we did not have any goniosynechiae or peripheral antisynechiae. So this is done. And we can just, I'm removing the lens now. We can just do a normal irrigation aspiration and close the surgery as we do it for a normal cataract surgery. So that's
Excellent. Excellent
done.
surgery, Dr. Ankur.
Thank you. And we could, I'm happy that we could see the Schlimm's canal despite. इसको सीधा करना है भैया बात इस माइक्रोस्कोप को. Uncle, सीधा कर लीजिए गर्दन
Now
को.
we are shifting
सीधा.
to
Ankur sir, if you're done with the surgery, can we
Yes.
shift to the other table?
Yes, yes, you
Yes,
can
we can
shift.
shift.
I'll just do the eye and do the hydration of the
Dr.
wounds.
Vishal?
That's all. पूरा सीधा
We
कर
are
दो.
shifting to the second
बस
case
बस
now.
बस अंकल
Dr.
सीधा
Mayank
बस
Sharma
आराम.
will be doing this.
आइए दे दे मेरे को बच्चे.
And this is a refractive surgery.
कोई सा भी दे दे क्या फर्क पड़ता है.
Am I
अभी
audible?
एक छेद नहीं किया तो क्यों करेंगे.
Yes,
Yeah,
you
yeah.
are audible.
So the
Microscope नीचे
refractive
करना
error
पड़ेगा.
is for right eye we are doing the surgery. The refractive error is minus 14.5 with minus 2.75 at 10 degrees I think, and AC depth is 3.34, white to white is 11.3, unremarkable retina, and now it's over to Dr. Mayank. Meanwhile, we can show the sheet.
कंटिन्यूस इरिगेशन ऑन कर दे. मशीन मेरे लिए बिल्कुल नहीं है बच्चे, है ना.
As it is shown in the sheet, we'll be implanting a minus 18 sphere and plus 2.5 diopter cylinder at 100 degrees. And
Can you show the map on the camera? Yeah.
the orientation is to counterclockwise rotate it by 5 degrees. 0, 180 degree are already marked, and we have to just counterclockwise the lens to 5 degrees. You can very well appreciate in the sheet now.
Are you able to see the sheet?
Yes, yes.
So,
Hi, Mayank. All ready?
yes.
Okay, you can start.
We have to understand about the loading of ICL, so which is a bit important to understand for each and every one. So we should put not much amount of visco. We should put some amount line and visco both. So this is a particular the well-designed cartridge from Star ICL. Now we just need to take out the ICL with the soft tip stick. So the convex side is upwards, and this is how we take it out. And loading on the cartridge is important. So first, we tuck one side of the ICL, and then gently with the help of soft tape, we just insert the other side also. So both the sides are tucked, and this ensures the upside down orientation of the ICL. So now this, with the help of this alligator forceps, we go and hold just ahead of the optics of the ICL and gently retract it. Sometimes it might remain in between, so you have to hold it again. So the hold should not be left. And once you ensure it's loaded in enough amount, now you have to take another soft tip, and with the help of this gun, we'll be loading it into the injector system.
You are using HPMC, the routine one, or a diluted HPMC here?
So diluted one definitely will suit, but if we are not getting exactly, we'll put some saline and a little bit of visco. Not much of visco should be given, because that will keep it a bit sticky, make it sticky. So now we load the cartridge with the injector.
The message is that we should be putting very little of visco, and it should be like diluted or
Yes.
thinned out, and we are not to use any higher order viscoelastic here.
So this is how this ICL has been loaded, and now what I'll do is just keep it in the ball of a saline, and I'll be doing the rest of the steps for ICL. Drip, drip.
Usually, you load the lens first and then make the incisions.
Yes, sir. Yes, sir.
So that should be the right approach. Because many a times, if while loading you lose the lens or something happens to the lens, at least we have not opened the eye. These are not like routine intraocular lenses that we have a library lying with us and we can use the other lens. What is the AC depth in this case?
3.34 is the AC depth.
And what is your cutoff value?
The cutoff value should be ideally below, around 3 only.
3.
We should try to avoid below 3, but yeah, in selective cases we go up to 2.9.
For the audience, this is the distance between the posterior surface of the cornea.
Yes, sir.
Not including the corneal thickness.
ऊपर कर बेटा. सूरज सिंह रिलैक्स है, तुम्हें कोई तकलीफ नहीं होगी. ओके, बस लाइट दिखाएंगे, उसको देखना. घबराओ मत तुम.
For the beginner, Dr. Mayank, do you recommend that it should be done under block or topical?
Sir, mostly we do it under topical. If we find the patient is very uncooperative, then definitely we can do it under local.
Okay.
So sir, light देखो, light के बीच में light नहीं देखोगे होगा नहीं. Refractive surgery definitely we wish to do it under topical only. चिन ऊपर करो, और ऊपर, फिर इधर करो. Very good. ऐसे ही देखते रहिए. So now we'll sheet the orientation of the ICL. Yeah, toric sheet, and we'll be rotating it anti-clockwise 5 degrees. So that marking we'll be doing now. Light के बीच में. Clockwise 5 degree. Counter-clockwise 5 degree. Yes. Light देखो. Dry करो.
Do you always use digital marking system for this, or like manual marking as you are doing?
Sir, we try to do both the things. and ड्राई बेटा मत हिला, रिलैक्स रह, तेरे को तकलीफ नहीं होगी, रिलैक्स रह. So counterclockwise 5-degree marking has been done. Do marking. Dry. लाइट देख बेटा, हिला मत, रिलैक्स है. तेरे कोई दिक्कत है तो मुंह से बोल, आंख मत घुमा. So for ICL, what we need is a entry of 3.2. And
So it
most
is
important thing is that we just take care not to touch the anterior capsule. Like that. So intracameral xylocard is being injected.
So the difference here is not 2.8. We are using a 3.2
It's
keratom.
3.2. Yes, sir. लाइट देखो सीताराम जी, हिलाओ मत, बहुत अच्छा करवा रहे हो. जस्ट टू इन्फ्लेट ट्राइपोड. We'll just make the side port also.
Again, the AC is not to be inflated too much.
Yes, sir. But should sufficient.
Yeah, sufficient to.
Yes. So now the most important part now is injecting of the ICL. I am removing the air bubbles and now. Okay.
I think Dr. Mayank, once he'll be injecting, you should just notice the direction in which we are injecting. That is different from the routine intraocular lens surgery.
It
Because
opens up exactly opposite to the other IOLs. So while injecting, we just take care that we inject it slowly. The convex side is up. So what I am trying to see is the opening up of the right haptic, leading haptic, which is marked. So until unless it's opened up well, we should wait, because so I have been successfully able to, beta light dekho, सीधा देखो, able to open up in the right orientation.
So our direction was parallel to the iris and we have gone above the iris here.
So what we can see now is that the leading haptic on the right side is having the mark, the opening, and similarly it's left trailing haptic. लाइट देखिए, सूरताराम जी लाइट देखिए, और सीधा देख बेटा, सीधा देख. हाँ सूरज सिंह नीचे देख. So what I can see is tucking of the right leading haptic, which has the mark, just to confirm the right orientation. And
so while you are putting the second haptic,
yes, sir,
leading haptic, you can just go slightly to the right side and then come back. So that also the haptic goes in very easily actually.
So I have
Very nicely done, Dr. Mayank. All the 4 haptics are now behind the iris.
So now I just wait not to keep it at the final position. I've just kept it, yes, visco. Yes, sir. Final position. Yes, sir. Yes, sir. Exactly.
Oh, Mayank,
Yes, sir.
since speaking in the OT, the voice is not clear. No, he's.
Can you just give some tips, Dr. Mayank, that how to remove the visco behind the lens?
Sir, not to go behind the lens in
Yeah.
ICL cases, we'll just be keeping it in above ICL only.
Yeah, that's what I'm asking. That
yes,
how
sir.
you tap that you take it out without going behind the lens.
Gentle tapping and just keeping it simple, and the IA should be continued, and just visualizing the visco getting removed. Okay.
Away the HPMC behind the lens.
One of the ways that has been described is that in the this has a central hole, I think the centraflex lens.
Yes, sir.
So just keep the fluid there.
Yes.
That will take out the viscoelastic.
Right.
You just irrigate through that hole so that the visco behind the lens will be flushed out. I think excellently done.
Yes, sir.
So now coming to the next case, Dr. Mukesh Sharma will be operating. The patient is a 64-year-old patient with keratometry 45.75 and 46.25. So he'll be implanting a monofocal lens, Vivinex Impress, and the power is 20. So
I shall be doing a Hoya Vivinex Impress lens, and this is.
Good afternoon, Mukesh sir.
Yeah. So am I audible?
Yes, sir. Clear.
Yes, sir.
All right. So this is a grade 2 to grade 3 cataract, and I shall saline डालो dry हो रहा है. I shall be implanting Hoya Vivinex Impress IOL. Light के बीच में देखिए. Here.
So this is a lens, Dr. Mukesh, which gives some amount of intermediate vision.
Yes. Here. Yes. So this is basically enhanced monofocal lens, and this gives some intermediate vision. And this is a new baby in the kit. Here I am staining the capsule. Light के बीच में देखिए. Viscosef, ये क्या है? नहीं, Hilon.
Now Hoya has also come out lately with this equivalent to Technis I-Hans, and
Yes.
Hoya has also come out with multifocal lens.
Yes. So here I am operating on a microscope which does not have a tiltable tube. So there is some issue because I am used to of that. But otherwise OT setup is beautiful. Here we are having I think 3 or 4 tables, and all of them are well equipped. I am operating on Elcon Centurion machine. Saline डालो dry हो रहा है. Yeah.
Mukesh sir.
Yeah.
The other person's voice is not clear. Who is in the OT? Ankur or Mayank sir?
Dr. Vishal,
हाँ जी बोलो.
is it audible now?
Not very clearly, but okay.
Okay.
Just the volume, if it can be increased slightly, or the mic you can bring it slightly nearer.
ये दूसरी दो.
Okay, I'll try.
Visco. I'm sorry that 26 gauge needle was rotating, so that's why I was thinking what is the problem. So this needle is rotating, so one must always check needles also, whether the needle is fine or not.
This is another tip that we have learned that.
So I was thinking why capsular flap is not lifting up, but instead of capsular flap, the needle was rotating.
So these are little few things that we should check before we go inside.
Correct.
One of the episode that happened was that once you are doing the hydrodissection, if the cannula is not snugly fitted, it is the cannula which will just pop in.
Light whisper. So very correctly said Dr. Neeraj. And since light के बीच में देखो माता जी, we have now become a kind of older generation surgeons and used to of our own setup, and sometimes we tend not to check these small little things. So it's a good lesson that every time whenever you enter in, try to check every little thing. So I generally tend to make little larger rexes. Bas 2.2. I don't like smaller rexes and having capsule or phimosis later on. Side port दूसरा.
So you are making the rexes from the main incision, but in a graded fashion, basically.
Yeah. लाइट के बीच में देखिए, लाइट के बीच में देखते रहिए. So I shall be doing hydrodissection and delineation also from the same 27 gauge cannula. लाइट ऐसे रखिए माता जी, लाइट के बीच में ही देखना है. हाँ. Echo machine. And chopper. So this is a new tip, and this is known as balance tip by Alcon. I am regularly working on signature, but it seems to be a very good balance. Saline डालो.
So this balance tip goes through 2.2, that is one advantage. And the second advantage is that with Centurion, this handles quite hard cataracts in a much lesser amount of energy.
Yeah.
But this balance tip is compatible only with Centurion, not with Infinity. So Dr. Dr. Mukesh is doing direct chop here. And I think, Dr. Mukesh, can you focus it slightly?
Actually, yeah, I am trying. I myself is not little comfortable here. Is it okay?
Better, but not very clear.
Actually, there is some problem.
Now it's better.
Okay, so they have adjusted the the camera focus probably.
Okay.
Sir, Dr. Mukesh, which chopper you are using in this case, sir?
This is sharp tip chopper, and I am doing direct chop here.
Yeah.
So this is a medium hard cataract.
It is no grade 3 cataract or so, but because of relatively new kind of setup, थोड़ा सा line डालो. It is taking a little time.
No, but it has been done very nicely.
Visco. So before withdrawing phacoprobe, ideally we should be injecting visco by manual.
So it is not only in posterior polar. Ideally, we should be injecting visco in all the cases.
Correct.
And we should keep the chamber inflated.
Correct. So I shall be doing bimanual IA. ये कौन सा है? बाईमैनुअल कोई और नहीं है क्या? लाइट के बीच में देखो, ये कौन सा है? अर्टली का है क्या है? अर्टली वाला दो ना, ये कौन सा लोकल है? हैं? अर्टली का दो। एक साइड पोर्ट और देना। अच्छा, ठीक है। इंट्रा कैमरल एडी है क्या?
So when we are using bimanual from this up and all, we need to have slightly larger side ports here.
Yes,
I think that is what Dr. Mukesh has enlarged the side ports.
Yes, it was not going through the standard port, so I had to light के बीच में देखो, enlarge it little bit. आइए कर दिया।
I think you can appreciate that some amount of surge is there in this case. That is because of the non-compatible bimanual IA probably. There is a piece here.
Yes, it has come out.
Better to take it with epinucleus mode.
इसको flush करना है. This port has been clogged actually. इसको flush करो, निकाल के इसको देना. एड्रेनलिन दे दो या वो दे दो। ये क्या है? फिनोकैन है तो फिनोकैन दे दो। Actually, the port of this bimanual got closed, so because of this lens matter, so I have told them to flush it. करो यार। Continuous irrigation on. लाइट के बीच में ही रखिए।
So this is manual feeding that Dr. Mukesh is doing, but this can only be done if it is a softer epinuclear piece.
Yes. My God.
I think there is a rent.
Yeah, there is a rent.
You better inject visco and
visco देना visco. There is a central rent actually, but it's a small rent, so एक बार लेंस दे देना मुझको। ये क्या है, लोडेड है क्या? एक वो देना मुझे इंट्राकैमरल कैनाकॉर्ड। So I am just injecting intracameral canaccord.
So now
just to check the strand with.
Yeah.
There is a small central rent, so एक बार मुझे स्वैप देना, ये देना।
So we need to check here whether there is any vitreous strands or not. That's why
Dr. Mukesh sir is injecting Canacort
Yeah.
to ensure that there is vitreous or not in the anterior chamber. And I think if the AC is clear, then we can use that iol tamponade.
Vitrectomy probe cutter. लाइट के बीच में देखिए कटर लगवा दो अगर नहीं है तो है हाइड्रो हाइड्रो हाइड्रो
So this will stain the vitreous strands if there are any.
लाइट के बीच में देखिए लाइट के बीच में देखिए लाइट के बीच में देखो लाइट के बीच में देखो इसको
I think we can inject some Viscot and take out this piece.
That's what I am doing it.
Because
Viscot.
Yeah. That's so better to put Viscot and take out this piece because this can.
So I am doing that. I am injecting Viscot only.
Yeah, sir.
और आइए देना एक बार मुझको चलो एक बार वो दे दो फेको लगा दो फटाफट they are just bringing out there is I think 1 or 2 strand so I am just taking out this and then I shall be completing the eye. There is no gross vitreous here, but maybe there are 1 or 2 strands in pupillary area. दे चॉपर दे दो डायलर दे दो कुछ भी दे दो दो इसको सेफ दे दो so that piece is out and अब मुझे आइए देना लाइट के बीच में देखो अब आइए दे दो Visco sir. So we are done with our IA and light के बीच में लाइट के बीच में देखना एक बार साफ देना ठीक है I have asked for cutter I think कर दो उधर. So I think we shall be implanting here a 3-piece lens because this has enlarged a bit. So I have asked them to arrange for a 3-piece lens. There is no gross vitreous anywhere. There is some vitreous strand in the pupillary area. So I think after implanting 3-piece lens, we shall be doing a limited vitrectomy over there. And once they can arrange the vitrectomy probe. Meanwhile, I think they are shifting on.
That is the actually absolutely correct approach that we need to shift to 3-piece lens.
Correct. Light के बीच में.
So now we'll be shifting to the other case. Dr. Virendra will be.
3-piece lens, one.
So
एक power कम का है ना.
Meanwhile, Dr. Mukesh Sharma will enlighten us about the impress lens. So
light के बीच में देखो.
So the message taken here is that we need to stain the vitreous, we need to remove the vitreous, and then we need to put a 3-piece lens if we are not able to convert the PC tear into a posterior capsular axis. So these 3 points are very important whenever we get a PCR. And the right thing that Dr. Mukesh did was that there was a piece So injecting viscot and then taking out the piece. Otherwise, if there would have been no vitreous and we would have cleared the cortical matter by then, we could have removed this piece with IOL scaffold technique also. That is putting a IOL first and then removing this piece.
So
And this
now
white thing is Kenacort. It is not lens matter. So this white thing is no need
that
of-
white was Kenacort basically. The bolus of Kenacort was floating basically.
it. Am I audible?
Yes, Dr. Virender.
Yes. So this is a patient with minus 10.25.
Yes, we can hear you.
Thank you. Thank you.
This is a case in which we are doing left eye with minus 10.25 and 0.25 cylinder. AC depth is 3.88. White to white is 11.9.
I would just like a second to thank Ikigami for providing the camera support for this live surgery. One is a 4K camera, I guess, and one is a 3-chip HD camera. Both are wonderful cameras. And Rajiv and his team from Ikigami have been always helpful to Roscon and conducting live surgeries on their cameras.
See the sheet.
लाइट के बीच में छोटे बिंदु दिखते हैं ना, वहाँ देखना है आपको.
So we had seen first a toric ICL being implanted, star ICL, and now a normal ICL will be implanted in this case.
So over to Dr. Virender Agarwal now.
Yes, Dr. Khungar, Dr. Vishal, thank you for this opportunity to do live surgery at ASGA. A wonderful setup, excellent staff, always smiling. I am doing ICL, and I must thank ICL also for sponsoring 2 surgeries this time. Usually they are very conservative. I prefer to do bimanual for IA in all cataracts and ICL, so I am making 2 side ports. Pupil is not fully dilated, so I will be using Phenocane, no financial interest, but this is a wonderful tool, I must say, in OT nowadays, because many patients we used to shout on the staff that why pupil is not dilated. योगेंद्र जी लाइट के बीच में देखना है, लाइट में देखना है बस. By the time you prepare your ICL, it will be dilated. So I am just shifting. लाइट से हटना नहीं है आपको, मैं लाइट को साइड में ले रहा हूँ, आप हटना नहीं. I will be loading ICL now. I agree with Khungar that you can load the IOL beforehand, but in this case, we wanted the people to dilate, and to save the time, we are using first Phenocane to dilate, only hydro. There are different opinions. I usually do this under only hydro, no visco.
So that's what we were discussing actually, that we should prefer either a diluted HPMC. So
ICL.
Yeah, but Dr.
Yeah,
Virender,
I agree. Different people have different choices, and there is some controversies also. This eye we are going to implant a spherical non-toric one. The patient is having a toric requirement in the other eye, but this eye is not requiring this thing. As the discussion was going on, I must continue that nowadays refractive surgery is taking front place in the surgical field and the requirement from the patients, and these kind of surgery can be done by everyone and no extra setup is required. The only thing required is a meticulous measurement, refraction, meticulous measurement for white to white, meticulous measurement for anterior chamber depth, that is from endothelium to anterior surface. And here I would like to put a word of caution that always do it in a natural pupil stage. If you do it in a place where pupil is dilated, it will not be correct. So that word of caution should be done, because many times what happens, once you do full workup, you realize that the patient is not fit for laser surgery. Gone are the days when we used to do only for high myopias.
The most important thing in ICL, apart from the surgery, is that the sizing has to be appropriate.
So I was, yes, you are correct, Fungar. I was coming to it, but I was seeing some fiber, so I stopped in between. So the important thing is that the ICL placement will depend on the size. And you have an important structure anterior to it, that is the cornea, angle, and posterior to it, that is the lens. You don't want to touch any. And this ICL floats very comfortably in the place what is very minimal otherwise in front of lens and behind the iris. It doesn't touch anything. Whenever it touches, it will have some complications. If it touches anteriorly, it will keep on releasing some or other pigments, glaucoma, crowding in the angle. I do again. The special tip what I do is that before locking it up, I again inject hydro. And once it is fluid, it will slide easily. Yeah. योगेंद्र जी लाइट में देखना है, लाइट में देखना है, विस्को. So we have used the phenocane to dilate the pupil. Now I am doing visco. हिलना नहीं है, लाइट के बीच में आई है.
Just
the
going
orientation of ICL while injecting should be that the leading haptic is having a hole, trailing haptic is having a hole, and that should be taken care. The leading haptic, and this is on the right side, have a hole. हिलना नहीं है भैया. बिल्कुल नहीं हिलना, लाइट में देखो बेटा.
Any
लाइट में
particular tip, Dr. Virender, about the length of the tunnel here?
I wanted to make slightly longer, but somehow the patient was not that very cooperative, slightly apprehensive, but still it is good enough. It should be slightly longer than this. The AC should be filled, and then when you inject the ICL, it should be very slow, gentle. It should not touch the cornea, it should not touch the lens. You should not be in hurry. You can see the ICL is going comfortably. I use visco again. लाइट में देखो बेटा, लाइट में देखो, लाइट में देखो. So I am injecting visco, and then I will be using. So here you can see that there is a hole. I hope it is visible there.
Yes, yes, it is visible.
So this is on the right leading. You should be very gentle. There is issues when pupil is too dilated. There are issues when pupil is less dilated. In too dilated pupil, it is sometimes difficult to put it behind the iris. In very small, you have to actually manipulate a lot of things. Sometimes it can touch the cornea, and sometimes when you press it hard, it can touch the lens. So you need to be very careful. Again, you can see a hole which is there on the trailing haptic, that is on the left side. Here you can see that there is no hole. So the ICL is real in upside down position the way we want. There are different approaches. You can do visco removal. It is a must to remove all visco. And I am fond of bimanual, so I will use the bimanual here also. Can you
give some tips, Dr. Virender, to check the vault somehow while we are on the table?
No, please come again. I could not hear.
I am saying that can you give some tip that is there any method that we can check the vault on the table?
Yeah, not exactly method, but now we have a slit lamp attached to the microscope, so you can use that facility. But otherwise, by experience, if it is having a too much volt, means it is a high volt, then the this ICL manipulation is a bit difficult. And on depth, you see that is getting kind of kink in the center.
Okay.
When it is too low, then there is an issue of otherwise that you will see that is almost touching. So you are seeing that the free visco movement behind the ICL, and in front of the IOL natural lens. That is very important. Vacuum कितना है अभी? Vacuum कितना है? 400. So complete visco removal is required, and as you were discussing before, and that we can use these holes for floating the visco from behind the ICL, and you should remove total visco. And as a routine, I use at the end of the surgery, I give 2 Diamox. I ask the patient to stay for 2 to 3 hours in my hospital, recheck the pressure. If it is within normal range, then only he is allowed to go home. Vacuum कम आ रहा है यार. Change करो टिप. Vacuum is not enough. हिलो नहीं योगेंद्र जी. Light में देखो, light में देखो, light में देखो, हिलो नहीं.
So here, never try to go back behind the lens ICL.
Yeah.
That is the basically teaching that we have to take a message.
Yeah, you are correct, because as I said in the beginning, behind the ICL and anterior to ICL, they are important structure, and we are doing a refractive surgery, and the refractive surgery result depends on the clarity of the media. If you touch the cornea, if you touch the lens, the clarity and the quality of vision will be compromised. So we should not do that. We should do meticulous cleaning. One word I will say that all ophthalmic surgeries require meticulousness, but when it comes for refractive surgery, it is requiring something else into your mindset, that you should not have any kind of attitude that chalta hai chal jayega. These are not old people. These are normal people in the sense that they have a normal vision, except the desire that they want to get rid of glasses. Maybe for the cosmetic reasons, but it's not always a cosmetic. They reduces the field of vision, and the biggest advantage of the ICL or phakic lenses is that they improve the vision after surgery in high myopes like this, -10, 12, 14, when we implant. The glasses which are doing minification, that part is taken care. There is a very good optics into the ICL that improves the vision in majority of the patients. So these kind of patients usually gain 1 to 2 lines from their previous vision what they were having with the glasses.
So they gain.
I am taking
vision.
extra time to remove all visco. But I must congratulate ASG people for having an excellent setup, excellent support staff, and all things are, whatever you demand is always available. I thought my number is after some surgery, so I didn't brought my instrument inside the OT, but somehow the number is changed because somebody else instrument was not autoclaved. So I jumped over in between and I have done my case.
That center hole, I think everyone can appreciate.
Yeah.
So that is why in the last case and this case, no PI has been done.
So we were doing PI 15 years, 16 years ago when we started ICL. Now for almost around 10 years, we are not doing PI. That saves time, and that saves sometimes the issues with the patient, because patient gets afraid of that. To get some surgery, you have to create a hole. Because whenever patient wanted to understand that what you are going to do before surgery as a whole, why it is required, so some patients were turning away and not getting the procedure done. Now that part is taken care.
So as rightly said by Dr. Virender, to avoid any pupillary block post-operatively, we used to do PI. But once this model has come out with central hole, then after that we usually, nowadays we are not doing any PI. And as far as the sizing is concerned, it is advised that we use a digital caliper and one other machine like a Pentacam or a Cirrus topographer or a IOL Master 700, and we should have white to white measurement very nice, because if that is not correct and it is an oversized lens, will lead into glaucoma, and if it is an undersized lens, will get into cataract.
Here I want to add on further to the Neeraj Kungal that still I believe maximum on the digital caliper. Whenever that is having some discrepancy with any other instruments, I do complete re-examination of the total investigations, that is including Pentacam, IOL Master, caliper measurement, and sometimes you have to get a caliper measurement done by some other third person in your hospital if it is having good enough. We have other consultants who will measure it and then cross-check. If it is not, then we ask the patient to come again. And again, I will repeat, AC depth should be in undilated patient. The specular count need to be 2,500 plus. What is this? Right. So that is the end of the surgery. the next day itself the patient feels wow. There is a big wow factor with this kind of patients who are in high myopia. Never ever thought of that the next day morning they can watch time before getting up, that what is the time in the clock, or wherever they go they feel wow, something is being done just drastically in day one.
Okay.
The same are the results with the LASIK also, but they are usually, now we are refusing for all high hypermopes. No, but ILI.
We can have
it is my habit to use this bimanual IA as a tool. That what I do, I press it over, I know the temperature, the pressure, and then again I hydrate it. So what all is there as a debris, something if it goes in, it is washed off. Thank you very much.
So
thank you, Dr. Virender. A small question, a short, quick question from the audience, if any, to Dr. Virender Agarwal. Okay, we can, regarding this ICL surgery.
हाँ, लाइट में देखो, कोई दिक्कत नहीं हुआ आपको.
I think we should shift to the next.
Dr. Virender?
Yes, sir. Now. We are
second OT is free.
We are ready with the Dr. Harshul's case. He'll be implanting in toric IOL, and the parameters are the flat K is 44, steep K is 45, and he'll be implanting 21.5. And model is Optiflex Trio 3 FLA 6, and power cylindrical power at IOL plane is 1.5 diopter. So over to Dr. Harshul now.
What is the axis where he is implanting?
9 degrees.
Line डालें please. नहीं रुक जाओ एक मिनट. Dr. Pratul, can you hear me?
Yes, yes, definitely.
Okay. So first let me just adjust table height up करेंगे please.
Okay.
Up.
So you already marked the cornea.
No. I'll just do everything.
You are using this Callisto.
Up. Just a minute, Dr. Pratul. I'll just adjust the microscope and up. फेको मशीन बस. लाइट में देखिए बाबा जी. So this case is planned for toric IOL implantation, and the axis where I'm going to implant the lens is 9 degree. Focus कर दीजिए जरा.
So 190 or 90 degree has already been marked.
So this is the marking which we have done on slit lamp.
So it will.
So this is 0 and 180 degree marking, and I
Can
put
we have the microscope feed?
Mendes degree gauge here.
Ashul boss, the microscope feed is
And
not
mark
coming.
9 degree here.
Ashul boss?
We are not getting the microscopic
We are not
view.
able to see the microscopic view.
सलाइन डाल देंगे प्लीज. थोड़ा सलाइन डाल दो कोई नहीं डाल दो. लाइट में देखिए बाबा जी. डाई दे देना मेरे को.
If you are doing during the surgery.
Can you see the microscope view now?
Yeah,
Yes.
microscope view.
Dr. Pratul, can you see the microscope
Yes,
view now?
yes, definitely.
Okay.
So
tell me.
So if you are marking now, then there is chances of cyclotorsion, na?
No, this is 0 180 degree, which is already marked on slit lamp.
Okay.
And what I'm going to do is I'm going to mark 9 degree around here. So I use 26 gauge needle, so that we have very thin marks there. This is the axis where we need to implant our toric IOL. टेबल घुमा दिया आपने मेरे इंस्ट्रूमेंट्स. हाँ. अब सलाइन डाल दीजिए प्लीज. विस्को लाइट में देखिए बाबा जी. So this is the 1.2 millimeter keratome which I use. Now these are calibrated keratomes so that when you are doing bimanual IA, your incision is neither, I need Phenocan plus please. So your incisions are adequately sized. They are not leaking side ports because they match with the bimanual IA which I use. Light में देखें, and this is the Phenocan plus which I use for topical cases. डाई देंगे मेरे को प्लीज और सलाइन दीजिए एक बार निडल हटा के वो कैनुला हटा के यस so if you have these lipid debris you should use this macro wash technique so that your cornea gets clear and this is a dye which I'll be using here because coaxial is not that good in this microscope so it's better if you have a denser cataract to stain it because Rex's sizing is key in toric IOLs. We all know that they should.
So you are not using air bubble?
No.
During this? Okay.
Visco, please. Visco. Just let me know if centration goes off. No, normal मेरा वो ना. Canal लगा ना yellow वाला? Yes. नहीं मैंने कोएक्सियल किया हुआ है ना नॉर्मल कर दो इसको हाँ नहीं और कर दो और कर सकते हैं चेंज नहीं इससे नहीं अभी कैसे देखना एडजस्ट करना हाँ ठीक है 15 number blade. Yes, Virendra sir, you were saying something?
Yeah, so I wanted to ask how many number of patients
he is not audible.
You are putting multifocal lenses or trifocal lenses?
Give me keratome. I'll come to that, sir. So now, no, 1.8. So I'll be using 1.8 millimeter phaco tip. So this is 1.8 millimeter keratome. Visco and cystitome. So this is a 25 gauge visco cannula. You can see this is modified by me. So advantage is that it goes easily through side port and it is tapered at the end. Rex's forceps देंगे एक मेरे को. विस्को देंगे प्लीज विजिबल नहीं होता
ग्लो नहीं है ना तुमने ग्लो एब्सेंट किया है
ओके नाउ
थोड़ा बेटर है
इल्यूमिनेशन कहाँ से बढ़ेगा कहाँ से बढ़ेगा
OTT
इल्यूमिनेशन
So Arjun, what is the size of axis you are planning? 5.5?
So I'm planning Rexes of 5.255 millimeter size, sir.
So that is an important point. You do all Rexes almost the same size for monofocal also. But for multifocal or trifocal lenses, this is a kind of must that to maintain the centration, it should be overlapping the IOL all around. जिसमें कंफर्टेबल हो रख लो एक्सेस कर लो फिर बाद में चेंज कर लेंगे
Virendra sir,
yes,
can you switch off the overhead light? It's causing a reflection.
Okay, Dr. Mayank, इसमें इधर एक तरफ की एक मिनट एक हाँ तुम जब भी करो ना जिस पे
so now we have Rexes which is of good size hydro please
इधर वाली हाँ और इसके बाद वाली भी बस
And this is the hydrodissection cannula.
So femtorexis is done by Herschel without using femto laser. Excellent.
So the advantage of this is modified by me, and this is advantage is you can do sub-incisional hydrodissection.
This
also
hydrodissection
nicely.
cannula is just like a Chang cannula, Chang hydrodissection cannula.
Yes.
Okay.
So
Give me
you're doing
visco.
multi-quadrantic hydro. There are people who want to do in one go. There are people who want to go in multiple points. Here you are going to inject very little fluid, and you are much more guarding the surgery and safety. Even in posterior polar cataract, sometimes it prevents your dehiscence in first go.
एक और है chopper इधर. Titanium.
Very good capsulexis, central and very 5 mm appropriate. Very.
Laser is fitted in Herschel's eye.
Herschel really very nice.
Yeah. Just a minute. Yeah. Foot switch देंगे मेरे को please. Foot switch.
Sanitation, Herschel.
Yeah. Continuous irrigation on. ठीक है. Is it centered there?
Yeah. Bit upside.
Now?
Now it's okay. Yeah. Now it's good.
सेटिंग क्या है बताएंगे मेरे को. 80% पावर कीजिए. 80 वैक्यूम 250 and flow rate 28 and pulse is on.
So it's a direct
लाइट में देखिए बाबू जी, लाइट में देखिए. So see, it's a denser kind of cataract, and for denser cataract, drill and chop technique, what I describe, it works best. You need to, और वो cool जो है ना 10% कर दीजिए, cool 10%. Cool है ना ऊपर 10%. नहीं cool. So in the center, when I drill, I'm weakening the central endonuclear core, rotating the nucleus and बाबा जी नीचे देख, छोटी नीचे करो, बस. So if you weaken it down, and now you hold it and chop, your chop becomes more effective. See, I have this split through and through. Can you see the split here?
Yes.
Yeah.
So again rotate it, hold it from one side and split it again. So once you have a crack like this, your job becomes easier.
So you have made a small pit so that the hard nucleus is approachable.
Yes, so this is the technique which I have been teaching for years. I presented in 2010 in Paris, drill and chop, what I call. Again see, so no wastage of energy here and there, you are just bang on target. Work in center, and this is all with 1.8. So tip size doesn't matter. You have better chamber stability. Lens खोल लीजिए please.
So surgery is a bit slow with 1.8, Herschel?
I don't feel.
It looks so there, but it is not slow, particularly with the earthly. If you talk about, it has a very good cutting capability. Then the things are controlled.
And the settings needed for 1.8 are much lower than what you need for 2.8 or 2.2. I'm just working on 250 vacuum, 28 flow rate, and you can see the kind of chopping which we can do. Again, hold in center, chop it. The whole game is of the good hold on the nuclear pieces. So once you have good hold, then only you can chop the nucleus nicely. And always remain in center, don't go in periphery because of the good fluidics. So basically this has a easy phaco technology. It has a tip which is physics. If you see the principle of physics, it attracts all the pieces because of good fluidics towards the tip.
Centering.
Yeah, I'll do that. Actually,
Yes,
XY is
yes.
not working that great in this. Lens ले लिया आपने please.
So you will enlarge the incision, or you will implant the from this
So
incision?
now see, we have different lenses which goes through 1.82 also, like Hoya and all lenses, they go through 2. For this lens, even if you have to enlarge the incision, it's not about the final incision size. The thing is intraoperative ease, and you have advantages in cases which have shallow anterior chamber, which have narrow angles, where there is less space to work, which have moderately dilated pupil. So your 1.8 tip, it gives advantages to you in those cases, and more fluidics are better.
So what is the advantage of 1.8 incision, Harshul?
So that's what I'm telling you.
It gives advantage in many situations, particularly when pupil is small. You have better control because of the small incision. That is a thing.
In IFIS cases also, in mild to moderate IFIS cases, your incision is small, you have advantage.
Right now we are having majority lenses coming which are compatible for 2.2 incision.
Visco
But
दीजिए
soon you
please.
will bring more lenses compatible to even 1.8 or lesser incisions. And it is just a mindset that 1.8 will not work. So 1.8 is good enough size for getting the phaco done in even hard cataracts.
Dr. Harshul, are you making
Light में
slightly
देखिए.
larger inner wound than the outer? So
Yes,
that your
slightly larger.
so that your maneuverability is easier inside.
Yes, slightly larger.
Center.
So especially when we are doing MICS, then our inner wound should be slightly larger so that we can move around in a better way.
So Harshul, which lens you are going to implant in this?
So I'm going to use Trio Toric lens, which is from Biotech, and it's a lens which is which has based on diffractive technology, and it's a totally lens which is made in Ireland, and we have been using the lens for now almost I think 2-3 years, and it gives wonderful results. It has add of 3.5 and 1.85 for intermediate, and the central 1.12 millimeter is the clean area, the central area, bullseye what we call, and it has 12 rings on the central 4 millimeter optical of the central 4 millimeter zone. And the beauty of this lens is that it utilizes almost 89% of the lights, so that there are less chances of glare halo in patients because more light is utilized. Can you see it clearly there? Is it
Yes.
centered? Okay. So this is a cortical matter. So always change hands when you.
What is the central
लाइट में देखिए
ring
बाबूजी,
size in
लाइट
this
में देखते
lens?
रहो. बहुत अच्छा है ना, बढ़िया.
Dr. Harshul, what
Yes.
is the central ring size in this lens?
Central ring size is 1.12.
Because larger the central ring size, the more forgiving the lens is basically.
Yes. Nowadays lenses have a larger central ring, so that we don't have to worry much about angle alpha, and in cases, so these are just pieces of. Okay, so now we have completed the irrigation aspiration. Keratome देंगे please. 2.4 दे दो, 2. वही दे दो, 1.8 दे दो मेरा.
So Harshul is a master for hydro implantation, and we are going to witness that again.
Light में देखते रहिए
So
बाबूजी.
the advantage of hydro implantation that you are not having visco at the end to remove.
एक मिनट वो दीजिए.
It saves your
Irrigation.
time, one step.
In toric lens,
Similarly,
it's
for
better
toric
no.
lenses, it becomes easy and good because these toric lenses which are
Light
having
lens
the
दीजिए.
chances of rotation with the visco
और मेरा
left
ये
over.
क्यूबलिन हुक देना है ना.
So there is no visco
Yeah.
remains at the end of the surgery. Mayank Agarwal. हाँ नहीं आप तो हाँ ये लेंस इम्प्लांट के बाद.
So the tip of the irrigation cannula remains above the optic, so that there are no chances that it will behave in a funny way. And after putting that, you can just rotate the lens to the desired.
I think beautiful
Sir, हाँ, बस
overlap
एक
of
मिनट.
the
So-
Give as a
IOL
tip
that you
for
can see
users who want to start using these trifocal, bifocal, or different type of multifocality lenses, because the next case is also for the trifocal. So please give one tip for the beginners.
So hydro stitch cannula दीजिए मेरे को. नहीं वो वाला मेरा वाला लगा के.
You have to center these lenses at the end of the surgery. You have to tap that they should be in the center.
लाइट में देखिए, लाइट में
The
देखिए.
hydro should be such that it is not overfilled chamber and it should not be leaky chamber. Because if it is leaky, then also there will be some decentration. If it is overfilled, then also there will be decentration. And you
Dr.
see the
Harshul,
Yes.
what are your experiences regarding post-op night glare and halos and ghost images and decrease in contrast sensitivity about this lens?
See, sir, any technology which is based on different, splitting the light, definitely we all know that it's going to decrease the contrast. It's there. No one can say that it won't be there. But as such, it depends on patient need. If patient wants to have, spectacle-free vision, so we have like toric and trifocal toric to correct astigmatism also. And, moreover now, I think Dr. Virendra will agree that it's been years we have been implanting, but hardly any cases are there where we had to explant the lens because of the complaint that I'm having so much glare or halo, something like this.
Then neuroadaptation also play a role.
Yes. So now we can see that the lens is rightly
well centered.
It's well centered. So we ask patient to look into this light. Light में देखिए जरा सीधा.
And now we are shifting to Dr.
Okay.
Mayank Agarwal.
So I
who is
finished
again going
this
to
case,
implant the trifocal.
and before I finish, I'd like to thank entire team of ASG.
Excellent surgery, Harshul. Very nice surgery. Excellent.
Especially Dr. Mayank, who has taken so much pain, and to my dear friend Dr. Arun Singhvi for building this empire. I'm so happy and thrilled to be here. Thank you so much.
Now over to Dr. Mayank Agarwal. He is going to do surgery on a Centurion.
Thank you.
And he is going to implant a VVNX geometric lens, which is again a trifocal kind of lens. There are VVNX geometry and geometry plus. There are two lenses. The patient is astigmatically neutral. Over to you, Dr. Mayank Agarwal.
Good afternoon, sir. So because of the paucity of the time, I started the surgery. I have made the side ports, done a capsular axis now. So again, the intention is to make a 5 mm of axis.
Excellent round, excellent center, and a perfect size axis. So as Dr. Harshul was saying that these kind of lenses are going to have some change in the contrast. Let me share my experience that nobody comes and says to you a complaint about the contrast for the reason because in India still we are operating, majority of the patients are already having a vision poorer than the 618. Once we start operating the patients who are having 6/6 and you implant, then they will say some complaint about the thing that contrast is changed or glare is the issue. Because of cataract itself also many patients already have a glare, though that kind of glare is different than the glare induced by the multifocality. So once you tell them that there is something which will be getting at the cost of something. So the cost is that you will see rings in the night vision, but you will get a freedom from glasses for most of your work. Then they agree to it. If you don't inform this kind of thing beforehand, then they doubt that something wrong has happened. That's why you are explaining now. So my advice is that explain it to the patient, then before it will be a savior. And I agree with Arshul that we have never explanted these lenses just because of this
Can we add on something,
complaint.
Virender?
And Dr. Pratul is very correct that neural patient takes over. So try to make the patient comfortable by counseling.
वीरेंद्र एक मिनट शांति यार एक मिनट हाँ ये समझ में नहीं आई क्या कंटिन्यूअस यू आर टॉकिंग वी कांट अंडरस्टैंड
No, Mayank is preparing the phaco parameters, that's why I was talking.
Dr. Virender was just telling that proper case selection is must, and a proper counseling, pre-op counseling is must in all these cases. These are not for every patient. We should understand that, and especially type A personalities. If you have some tests with your counselor which can find out that a type A personality patient has come, there we have to be very careful.
Night drivers especially.
Viren, can I add on something, please? If you allow me, Virender? I think the incision is too hot. That's why the iris is coming out. It's an early entry into the cornea, so I think you can just make a blade entry just over this incision. Leave this incision, make the anterior entry a little anterior. It won't happen then. Can you hear me?
So, Mayank sir, can you hear us?
Yeah.
Virender sir, can you hear us?
So Dr. Virender has left the OT and now
Dr. Mayank,
yes sir. Dr. Mayank is
could
there.
you get the tip from Dr. Khokhar? Dr. Khokhar is here with us now.
So,
Sir, I got this tip into the OT only.
so now
So I am doing a direct chop, done a direct chop. Taking out pieces one by one. It's a softer cataract, so I am using just the torsional power. No longitudinal phaco is being used. Excellent followability. The pieces are coming off their own. Visco.
Is this patient Urimax by any chance? Virender, is this patient on Urimax?
Patient, I don't know, sir.
Can someone look at the file and see whether this is a patient of prostatic hypertrophy on treatment on Urimax?
By manual. Yes, sir. Tamsulosin is known to cause floppy iris.
लाइट के बीच में देखिए। What's that?
So if you are doing hydrodelineation, then this epinucleus is a troublesome thing. Yeah, this is because of hydrodelineation. So it's better to do only hydrodissection. Once you do hydrodelineation, then this epinucleus is very troublesome.
But it gives you a good cushion while you are operating also, no?
Yeah, but afterward it's a big hazard.
So we welcome Dr. Khokar sir. Sir, I was absent for a short while. For some reason, I was out of the OT.
Dilator.
We welcome
Virender, can you be slightly louder?
Yes, sir.
Can you bring your mic slightly close to your mouth?
Okay.
Hi, Virender. How are you?
Can you hear me now?
Yeah.
Yes, sir. Yes,
Now
sir.
it is here Virender's voice.
Virender, was this patient on Tamsin or something? Because iris is fluttery. There could be two reasons. One could be the incision is too hot. The second could be a patient is medication.
Probably patient is on, I had not asked, temsulosine or something.
Diler.
Yeah. So in these cases, if you can put preoperative atropine ointment for a day or two, the strength, the iris behaves much better.
Yeah, so that is a tip we should know for these kind of situations, because now many patients are actually on this drug. So this kind of manipulation,
epinucleus
fluid is not being used, so you can maintain the chamber well and you can dislodge it and then aspirate. But Dr. Kaur sir was very correct that these kind of patients require some extra medications and precautions, and you can keep the flow and especially flow rate also.
Yeah. And you can actually make a longer valves in these patients rather than making short valves. If you make a longer, more into the cornea, the chances of prolapse reduces in these patients.
So he was using this Centurion machine and the IOP setting was 60. So I asked him to reduce to 40, and now you can see the chamber is much more stable. So that is the advantage of this kind of machines. And the parameters are very, very important, particularly for these patients. So Kokar sir, what is your settings for these kind of patients?
Yeah, okay. So what I do is, for the beginners, I recommend is you can actually go to the response time. This machine has good response time. So if you want to have a good response time, you stay on 1, or if you're a fast surgeon, go to 2. Otherwise, in fact, you can go to minus also in these ones. So that means everything is going on a slow motion. So you don't have more complex. I stay at 1. I normally stay at 1. And as I said, I always start these patients pre-operative on cycloplegics 2 days before. In fact, I can go to the extent to use atropine sometimes in these patients, ointment. And I operated one of those VIPs about 10 years back in which I had the same kind of problems. And after that, I started using atropine ointment and never had a problem again. So you people can try and come back if that actually works.
So I agree with you, sir. What is your experience that initially people used to say that you should be off the temsulosine for 10 days, 20 days, 1 month. Do you find some differences there by keeping it off?
Off the drug does not make a difference, because once the nature of the iris has changed, even if you stop the medication, it's not going to go away.
Yeah.
So I'll be implanting this geometric lens. It's a trifocal with an 2.75 for intermediate and 3.5 for near. It's an adjustable tip also, but I would like to prefer this only. It is compatible to go through 1.8 mm incision. One tooth.
So as you were discussing just before this, that now the lenses are also coming with which can go through 1.8 millimeter incision. So everybody try to shift on smaller incisions is a big advantage.
So it has both rotation as well as the shooter mechanism. I prefer it to do it through a rotation. See, the leading haptic is going in well.
Thoda sa center. Better. So you see that these kind of injectors which are preloaded have an advantage to the surgeon. You don't require to load them. It saves your time, and they have a very guarded delivery system. And now almost all companies are coming with the preloaded lenses. This iris, you know, is not having a normal nature. So
this Hoya lens has a best delivery system.
So, Mayank, what is your experience of using this geometric lens and other trifocal lenses? How you feel that this lens have an advantage over the others?
So practically saying, sir, no extra advantage. It is just that they come with a family of two. One is geometric, one is geometric plus, and if we combine, we have a continuous range of vision. I am just analyzing my results only. I have done only 16 or 17 cases till now. So I am just waiting for the follow-ups to come. Second is the number of rings. They have only got 4 pairs of rings. So might be that the glare and halos may be little lesser than as compared to other lenses.
So now the time is coming when we were using these multifocal lenses diffractive to start with. They were having full rings, and the addition was almost 4 diopter for near point. Now it is being reduced to 3.5 or 3.25 in majority, and because of that also the things have changed. Number of rings are also changed. The pattern using for the different steps is also changed. We are shifting to another surgery done by Dr. Arun Shatpal, who is a volume surgeon, fast surgeon, and he gives the tips which are very useful for everyone, not only for beginners. And every time I see him doing live surgery, he gives special tips. So it is a good learning. Excellent surgery done by Mayank. Clap.
Thank you, sir. Thank you.
Am I audible?
So the Hoya lenses presently have the best delivery system, as we have seen, and they can go like there is a Hoya Nanex lens, Hoya Vivinex lens, and these are on the platform of Hoya Vivinex lens, the lens that we saw which was implanted.
So can you hear Dr. Arun Shatpal in the auditorium?
Good evening, everybody. Can you hear me?
Yeah.
Am I loud and clear?
Dr. Khungar?
Sir, you are audible, loud and clear.
That's wonderful.
But your feed is not coming here in the hall, so can you request the yes? Now
Yeah.
it is there.
Okay.
You've already done a access.
So to save time, I have already done a capsular access, and I'll be starting with a hydrodissection.
So what's the size of this Rex? Is 4.75 or?
This is, yeah, I wanted to make it 5, but slightly conservative. It is somewhere between 4.5 and 5. And here I am doing a hydrodissection.
There is a break in your voice, Dr. Arun.
Can somebody adjust the mic, please?
Yeah, now it's better.
What you want?
Mic adjust. Adjust the mic. Now can you hear me?
Yeah.
Okay. So this is a 2.5 millimeter, 2.8 millimeter incision, and since we have a 2.8 millimeter tip, so that's why I'm going through a 2.8. So after doing a hydrodissection, I'm decompressing the bag, and once I've decompressed the bag, chopper.
So
We will try and rotate the nucleus.
Arun sir, which machine are you using?
I'm going to use Earthly. Earthly is my favorite machine, and I'm a hardcore fan of Earthly. No financial interest. So I'm trying and rotating the nucleus. And now we'll start with the phaco.
So now to use 2.8 millimeter looks me that it becomes too fast. When you control the incision size, the tip size becomes smaller and it becomes controlled phaco. But the excellent surgeon, Dr. Arun Shatpal, is going to show you that how this can be used to save time during the surgery itself.
So my preference for this lens is 2.2. Can I have some saline on the cornea, please? So I go bury my tip, and I try and hear the occlusion sound. Once I have a occlusion sound, I come back in foot pedal position number 2 and do a direct chop. Once I've done a chop, you try and rotate the nucleus, and so now I have a occlusion and another fragment.
So Arun, as you were saying that these kind of lenses which are not very hard will you prefer same 2.8 or 2.2, or you change the tips according to case?
I usually prefer 2.2 in each and every case, until unless it is a hard brown cataract.
Yeah.
So, but here we don't have a 2.2 right now with Utley, and Utley I wanted to use.
Good.
So
this is good thing.
And I have half of the nucleus is gone. Now, if you can appreciate that my side port incision was slightly big, and the iris is trying to come out of that place.
Dr. Kapil कहाँ गए? अच्छा. So, Dr. Piyush,
Nucleus gone.
Would you like to say something about the 2.2 and 2.8 tip?
Actually, I would say that it is the surgeon's SIA which actually would decide that which tip to be used. Many of the patients, if we see pre-operatively, they have a astigmatism at 180 degrees or at 90. Like, howsoever we evaluate, we can see if our SIA with 2.8 or 2.2, how much that is differ. We do not need actually a total astigmatic neutral incision. Sometimes if it is inducing a 0.3 or a 0.4, it may be rather helpful to actually calibrate and reduce the astigmatism whatsoever it may be pre-operatively. So I preferably use the incision size according to the pre-operative astigmatism, and also use a combination of LRI through flax or, just modulating my incision and try to neutralize the astigmatism to the minimal possible.
Piyush, you said you will change the incision size depending on the keratometry of the patient, right? The cylinder.
So now I am going on to irrigation and aspiration. You can use a bimanual, you can use a coaxial, or you can use what I am using, a Simcoe's cannula, and whatever you are comfortable with. There's no hard and fast rule in this, but the only thing is that there should be no leakage from the main port incision. I'll be implanting a lucidus in this. So lucidus is basically an advanced monofocal, or you can say it's a EDOF sort of a lens, which has a bump in the center, and it has an addition of 3 or 3.5 in the center. Can you hear me?
Yeah, we can hear you. Is it something like Alcon Vivity?
Just in the center it has that about 1.5 millimeter, and the rest of the lens has the power for the distance.
This lens is by which company? IOCare.
No, this lucidus is not by IOCare, it is a Swiss company. So we are done with the irrigation aspiration. Can I have some viscoelastic?
It is a Swiss made lens and it is hydrophilic.
This is a hydrophilic lens. That is the only disadvantage of this lens. So we still don't know about the long-term PCO rate with this lens.
Yeah.
But the only advantage I get is that I don't have to counsel the patient too much for this lens, because there are no rings and nothing, so no chances of load kar diya? Okay, they have already loaded the lens. I wanted to show you the lens before loading. Anyway, so this lens can go through 2.2 as well, and see the lens coming out. It has a closed loop haptic.
And optical diameter is also 6.5 millimeter.
Yes.
Of this lens.
And the lens goes in. And we need to center this lens, and I don't know whether you can appreciate this center 1.5 millimeter bump in the center.
Yeah.
If it is visible.
Very
so
clearly visible.
This need to align. We need to align this with the Purkinje image. and I can see in my microscope that it is very well aligned to the Purkinje image.
Coker, is it
Excellent one.
similar to VVT, this bump? Like, is it functioning?
I think the Swiss guys have.
This is a
yeah.
Swiss lens, hydrophilic.
Yeah, the only thing going against hydrophilicity, and the second is the bump in the center can actually give a halo sometimes to these patients, and this might be pupil dependent also.
Yes, yes, that is if the pupil is small.
Yeah.
Then there's a problem with this.
Yeah, because most of these one which have a refractive more than the diffractive will always have density. So.
And you see some bump as well as some rings around that bump.
Around that bump.
So, Arun and Dr. Khokar sir, I will ask your opinion about the distance vision feeling with this kind of lens vis-a-vis trifocal, multifocal or CRV vis-a-vis monofocal.
So I have implanted about 40-50 lenses. 1 or 2 patients have complained about the halos in the night. One of them is a doctor. And the vision is excellent with this, especially the near vision. You get most of the cases get 6x6 near vision and 6/9 and N6 in the near and 6/6/6/9 for the distance. So I'm otherwise very happy with the lens, and of course we counsel the patient that this is not a multifocal or a trifocal lens. I have some lens metal lying here, so I'm trying and pulling it out.
And how many patients have come and said that, sir, it is not ring free? There are some rings visible to some patients, or nobody is saying this?
No, only I think one patient has come and complained about that.
Okay.
I think Virendra, if you tell the patient that there are rings in the lens, the chances are that 80 to 90% will complain. So if you don't tell them, they don't know about it.
Yes, I think that's.
No, but I tell them when I implant ring lenses. I tell them I'm implanting a ring for distance and near vision. So you will see the rings, but you will get.
So we are done with the removal of viscoelastic, and now I'm going to seal the incision.
So now we are going to introduce a bullet trained Dr. Kapil Vora.
Yes, you're saying something?
Dr. Arun, size of the rexis, I think it is. What should be the size of the rexis?
You want me to enlarge it? I can enlarge it still.
I think you should enlarge it because this is a philic lens. There will be more chance of contraction. So you should
That's
enlarge
why
it.
I'm asking.
So I'll enlarge
it. It is a multifocal lens, and rexis.
And the size
should be.
Yeah, at least
little bit
4.5 to 5 minutes.
So I'll enlarge it.
Arun, there's one more question. Can I ask you one more question?
Sure,
please?
sir. Sure, please.
Okay.
Yeah.
So one is that when you do a bimanual aspiration with a high speed and a high suction to the tune of 500 and you're doing with a Simcoe's, do you find that the chance of VO high? Because I'm sure the micro cells will not come out from the bag with a Simcoe's cannula. So what I feel is that you should always use a suction with a high vacuum in these ones.
Point taken, sir, but I'm so used to this, and my like this is a I think Visu 150 microscope. Had I had my Lumera eye, then the cleaning is very good with Lumera eye. You can see a lot of cells and everything, and so
yeah, you can use a bimanual. But the coaxial, you can use bimanual. So one hand will always control the eye, and you can always rotate the eye. So what I suggest you should always do a aspiration rather than Simcoe.
Point taken, sir.
So we are
I'm here enlarging
extending the rexis to a proper size, and as soon as he finishes this rexis, we are going to shift to Dr. Kapil Vora. He is a bullet trained for cataract surgery, and you all must witness how good he is and how fast he is. Please shift to table 2.
So I've finished up with enlarging the rexis as well. Thank you very much, everybody.
Excellent surgery, Arun.
Thank you very much, and excellent staff and excellent arrangements in the OT. Really appreciable.
Thank you, Dr. Arun. Very nicely done surgery.
Khokar sir, Dr. Kapil Vora is audible to you.
Kapil, क्या हाल है? चंगे?
So
रेड ग्लो को शिफ्ट करना है, ग्लो नहीं आ रहा।
क्लियर है।
माइक्रोसॉफ्ट पीपल ग्लो थोड़ा शिफ्ट करना है, ग्लो।
अभी ठीक है?
कुछ आया?
नो बट ये छोटा हो गया, फील्ड छोटा हो गया।
फील्ड छोटा।
मैं डॉक्टर साहब को हेल्प करवाया। हाँ
नहीं
बीच में, यस बेटर, यस एक नहीं अभी भी ग्लो नहीं आ रहा सर। बेटा एक जना इधर लगाओ, ये पूल को है ना साफ कर ले, इधर पूल हो गया साफ। एक जना वॉश पर्सन इधर आओ बेटा, इधर पूल हो, थोड़ा सा पूल को हटा दो, विजिबिलिटी नहीं आ रही।
सॉफ्ट है।
नहीं विजिबिलिटी एक बार बेटर कर।
मैं बस ये लगा दूं सर, अब जैसे मर्जी कर।
या अब उसको सर आप ग्लो को थोड़ा वापस शिफ्ट करो ग्लो को।
हाँ
या सर बीच में
राइट,
बीच में आया था, थोड़ा इधर वापस लाओ और थोड़ा लाओ।
कि इसका एंगल चेंज करके कुछ आता है।
अब आप देखो कि नहीं इससे कम है।
अभी देखिए,
अब थोड़ा बेटर है। Is it clearly visible there?
You see the glow?
Yes, yes.
Because it is not visible here, maybe because of the monitor, sir.
Yeah.
Okay, sir. So we are done with the hydrodissection part. So as this is the chopper that I use, and you can see the nucleus moving.
So you can see the rotation of the nucleus.
Kapil, focus. Can you focus a little more, please?
Okay, sir. Yeah.
And little zoom in, and that should be good. Thank you.
Is it okay?
Not yet.
Not, this is blurry.
No. Focus, please. Focus first. Onto the iris. That will be good. No, not yet. You're going other way around. Little down.
Sir, this is Visu 150. I think this is the best focus that we can achieve.
Fine. Go ahead, please.
Okay.
I hope you're seeing properly from your end.
For him also a slight compromise, but whenever you change microscopes, you need some time for adaptation.
Okay. So tip ठीक है ये जैसे लिखी हुई है. Okay, sir. Using this machine for the first time. Okay. इतना से ठीक. Zoom is okay. Using this machine for the first time, I've heard a lot about this machine. So let's see. Light में देखेंगे.
हाँ. बेटा एक मिनट रुकना.
थोड़ा रिंगर डाल देंगे.
आपके कितनी बची हैं तुम्हारी?
थोड़ा रिंगर डाल देंगे कॉर्निया पे.
नहीं अभी तक तो अच्छी चीज़ है.
कॉर्निया पे वैसे नहीं रिंगर दिक्कत.
हाँ ये तो अच्छी चीज़ है. हमने होल तो
बस थैंक
यू. इसके बाद मैं JNG की डेफर सर्जरी कर देता हूँ.
सॉफ्ट है यार, क्या ज़्यादा ही
है ना. नहीं क्योंकि जैसे क्या हुआ ना वो तो लास्ट हो जाएगा, वो चिल्लाएगा आपके ऊपर, है ना. हाँ है ना. तो इसको आप संभालिए, मैं देख के आता हूँ. मैंने मेल मंगाई है, डाउनलोड हो गई ना सर, तो फिर आप बोल रहे हैं.
That's very fast. And Kapil, have you used this balance needle before? You're using a balance on a Centurion, I believe.
Pardon, sir?
This needle is called a balance needle on Centurion. So you have you used it before?
No, never.
You see, it's got two.
I've never used the machine even.
Okay. So the
because
only
I sir operate on Venturi pumps.
Okay. The only advantage here is it has an ABS system. If you pull the sleeve out, you see an opening on the needle. It's a hole which is called the aspiration bypass system.
Okay, sir.
So when you put the aspiration, your vacuum has to be to the tune of 550. Then only you'll have a better grip in these.
Okay.
For the less suctions, the grip will not be as good.
Coaxial है मतलब. आइए. Shifting to IA. It's a wonderful machine, sir.
Yeah, you'll see. This is with there's a new machine which I cover with a Sentry. This one with a Sentry or without Sentry.
Fine vision PhysiIOL, PhysiIOL trifocal.
So which IOL are you going to use, sir?
Sir, PhysiIOL trifocal.
This is a
Fine vision.
trifocal fine vision from Physio.
So what are the advantages you feel over this?
Sir, we shouldn't be comparing to other lenses, but the thing which is very good with PhysiIOL is that it permits almost 91.5% of light to pass through. So the light loss is very less in PhysiIOL. And the second thing is that it was the first lens which used 2 diffractive platforms. So because of these 2 diffractive platforms, the intermediate vision is very good in this lens. So, and I have implanted a few lenses, other lenses also. And I find that कुछ polish है? हाँ, polish is it?
When we are doing a coaxial IA, using coaxial IA and taking the subincisional, I think the slightly curved coaxial that we have works better.
Yeah. So because of these 2 diffractive platforms, the intermediate vision is very good without any additional light loss. बस lens काफी है.
So I feel there has been a good experience with the surgeons about Physio so far. And we have also...
See, Physiol was the first company to introduce a trifocal lens around 10 years back. Okay. So there was no concept of trifocal lens in those days. We were using only we used to call them multifocals or the bifocals. Okay, okay. Loaded? Okay, right. Was injecting करना है ना मैंने तो. So this is, I am adjusting the lens, bringing it near to the tip. The injector is very good. Right में देखें मैं हो गया बस तुम्हारा चिंता ना करो. And it is a 4-loop lens, very stable, hardly any rotation after implantation, and a very good, can prove to be a very good toric lens also. And the way to inject this is just introduce the leading haptics into the rexus, and then you just press the lens. So the pupil is not fully dilated, so that's giving us a problem. Do we have some epitate kind of thing? Visco देते हैं कुछ deep कर लें इसको. Done. So here you can see that, and then we can set it as per the Purkinje images right in the center, and here you see. Right. Bang in the center of the Purkinje image. Light, Mataji, light में देखो. Yeah. So thank you very much. I'll be doing IA now.
Thank you, sir.
Surgery is over.
Now we'll shift into the next case.
Yeah, थोड़ा. लाइट पे देखेंगे मां, लाइट ऑपरेशन हो गया आपका. लाइट को देखो, लाइट में देखो, लाइट में देखो, बहुत बढ़िया हो गया. या थोड़ा सा ग्रीनरी है ना बस.
The front tip at around 70 degree and the proximal bend is around 70 degree. So you can see the bend of the needle with which I can guide my rexus under the direct vision. The pre-op toric marking has already been done on slit lamp only. So just slide down. Now I'm going to give my incision, that is 2.8, along the steep axis. Concentration मेरे को तो ठीक है, कुछ कैमरा थोड़ा सा इसको टिल्ट कर देते हैं. So I'm 2.8. I'm going to make my incision right now. I'm going to make my incision on the steep axis. No,
Dr.
no,
Kilnani, sir.
I've entered into the anterior chamber right now.
Yes, Dr. Virendra.
डॉक्टर राजन की आवाज आ रही है वहाँ पे ओटी में?
हाँ, आ रही है. It's coming.
So I'm going to put visco right now.
No,
visco.
The voice is clear.
Yeah. Just putting little bit of visco on cornea. It makes our media more clear. So I fill the chamber with the viscoelastic, 15 degree. I'm going to make my side port right now. Capsulotomy. I'm going to start my capsulotomy, capsular axis. I'll aim at around 5 to 5.5 millimeter of axis. Saline डालते रहना कोने में. So I'll give a scratch in the center into the anterior capsule. Because the glow is very good, so I have not used any dye for this.
We can see with good retroillumination, the axis is being done without staining the anti-capsule. Rajan sir is seeing this retroillumination very well. He hasn't stained.
You see, I'm guiding by the axis. You can see your tip of the needle guiding that axis very well. So I made around 4.5 to 5 millimeter of axis hydro saline. Yeah. So 5 mm. I'm going to do my hydro dissection right now. It's so that I can separate my nucleus from the cortex.
So this is a toric lens, magnificent toric, which is called advanced monofocal, and it's from IOC care group. And toricity can also be corrected with it. So we are planning to implant it exactly at 86 degree. So the marking is already there, and we are through with hydro dissection now.
Because it is around grade 2 to grade 3 nucleus, patient is diabetic. So I've done the hydro dissection right now. I'll put the visco and check the nucleus rotation by using a Sinski's hook.
Sir, lot of debris is there over cornea.
Wash
Yes, sir. Yeah, washing.
नहीं saline wash कर दे अच्छे flush.
There is, yeah.
Still debris are there. So थोड़ा सा विस्को डालना एक बार. थोड़ा सा वो हो जाएगा.
My nucleus is still not free from adhesions, so trying to rotate it so that I can emulsify easily afterwards. Feco 1P है ना? Hardly. I'm going to use Feco 1 पे ना? हाँ. But just first, initially, Feco 1, Feco 2, I'll do the direct chop. Because it is a very soft nucleus, So I think chopping may not be ideally done in this patient. So I have to go to the FACO 2 settings directly, and I think for the beginners it is not a very good case, because the most of the complications are happen in such type of soft cataracts. It's not easy to trench this nucleus, so I will use flip and chip technique only. That is just, I'll try to eat it in a piecemeal. हाँ सलाइन डालते हैं, वॉश करते हैं. As you see, I am using just a basic machine by RT. It has a flare tip technology, so it gives a very good holding of the nucleus. In hard cases, it is especially it's very beneficial. Go off. हाँ, चल इसको दो. Because in the center the nucleus is very soft, the patient is diabetic, so I'm trying to free the nucleus using the dialer. Now I am able to rotate this. हाँ सलाइन डालते हैं, वॉश कर.
This is a softer cataract, and we can see this. We're trying to remove apinucleus. I feel Rajan is going to flip it now.
Visco देखो. So I'll again the visco will try to dislodge this nucleus from the periphery. एक डायलर और दे दोगे. So I'll go through the main port and will try to go into the bag. So I'm trying to disengage this nucleus from the periphery. Once it comes to the center, then it's very easy to aspirate then. Because in such type of cataracts, you have to use the epinuclear settings with a low phaco power and good vacuum.
Dr. Rajan, by forceful hydro dissection, forceful hydro, we can lift up this bowel and aspirate this after putting visco behind this.
Sir, I pushed visco into the AC. एक dialer और दे दो. And now I'll try to use 2 dialers. I stabilize the eyeball with one Sinskis hook. I am trying to disengage the soft cataract. I don't want to go into the periphery to pick up that nuclear pieces.
Dr. Rajan?
Yes, sir.
Do a forceful hydro dissection and then it will be come anteriorly. This
Okay.
whole sheet.
Okay, sir.
Yeah, yeah.
I'll try.
Right, yeah.
Slide.
Go behind this rhexis margin and push lot of fluid. Yeah. Yeah.
Now I am able to dislodge the nucleus right now. No, fake. Saline then. I have moved the core of the nucleus, but the epinucleus is sticky right now. So I'll try to dislodge with the hydrodissection it into the out of the bag.
First.
इसको देना है तुम्हारे पास एक वो होता है ना न्यूक्लियर पॉलिशर टाइप होता है वो इंस्ट्रूमेंट है क्या दिखाना है पॉलिशर नहीं होता एक दूसरा होता है वो स्पेचुला टाइप होता है वो
So this is the role of patience, what Dr. Rajan Gupta has shown, that he is meticulous, he is patient, and is trying to show that how to deal with such situations when the nucleus is sticky, the epinucleus is sticky, and there is a soft cataract.
Phenokin plus.
So this is one good tip that you can use some mechanical dissection and dislodgement of these nuclear pieces in a place where you can eat them up with the phaco.
As my pupil was going down, I put in the Phenokin plus intracamerally to dilate the pupil pharmacologically. So as you can see in the periphery, still my epinucleus is there and it's sticky. I don't want to venture into the periphery, so it may lead to the PC rupture and may
So what phaco parameters you will advise for this situation?
Sir, be cool and calm.
Yeah, that we are seeing you are very cool and calm.
That is the most and because we have to give the vision to the patient, not to create any complication. I'm trying to remove it mechanically. You can see I've removed it mechanically.
Excellent
With the
dissection done.
hook. I'm using only Sesky hook. You can see only one instrument I'm using for it, for all the maneuvers in such cases.
So it's good that don't use chopper, use some soft tip or blunt tip instruments. Very good tip.
Light में देखना श्याम जी. See,
excellent.
Just it was a gentle mechanical dissection into the fornices. The only tip is remain in the center. Don't venture with a phaco probe into the periphery. because in the center the bag is deepest. Now you can see I have removed almost all of the nucleus. Now I'll go for irrigation and aspiration by manual. I won't use any bimanual, I use only coaxial.
Excellent demonstration of cool, calm, and meticulousness.
See, the minimum phaco power was used in this case. And you can see I rarely use the instrument in my left hand, because you can stabilize your eyeball with one instrument only. And it doesn't put any pressure upon the eyeball.
So Rajan, which lens you are going to implant in this patient?
Sir, I am going to implant magnificent toric lens. That is a EDOF lens by Phenokin Plus. So my pupil is again going down, Phenokin Plus. I am going to put intracameral Phenokin Plus.
So what are the special features of this magnificent trifocal lens from the
So it's not trifocal, I am going to use EDOF, not trifocal, sir.
Okay, good. So do you require to give some near addition for these patients, or they are able to do their activities?
Sir, in by this lens they will able to go for intermediate vision activities like using mobiles and laptops from intermediate distance of around 60 to 70 centimeters. Generally the near addition required in such cases is around 1 to 1.25 diopters.
Good. Good.
Now again I am visco dissecting this cortex, because I was not able to pull up because it was also sticky. So I inflated the bag again. Now I can again dissect it with the dialer as well. Since case hook. See the mechanical dissection of the cortex.
So in these soft cases, you see that they are layer by layer, the epinucleus and the cortex, which need to be removed. For safety, you can't go and chop them, you can't go and aspirate them with the phaco so easily. And excellent show done by Dr. Rajan. In such situations, I would like to have opinion of the house that when the nucleus is soft, the epicortex is there, and using coaxial or bimanual. Any opinion from?
I think it's better to use bimanual because you can change the hands and you can access the subincisional cortex in better way using bimanual irrigation aspiration. One of the limitation of the coaxial is that subincisional cortex is difficult to take out, and sometimes some companies they came up with the curved coaxial, but most of the surgeons now prefer the bimanual irrigation aspiration.
Sir, one drawback with the bimanual is because you have to make the larger ports. So I think the chamber stability is less in case of this bimanual IA.
Yes, I agree with you that if the incision are larger, side port incision are larger, then there can be issue of chamber instability. And secondly, if the port of the bimanual is little smaller, and sometimes then can chamber instability can be an issue.
He has demonstrated a very well aspiration of the subincisional part, and for the remaining he is still showing us the skill. That is a big advantage of having a skilled surgeon, that he can use coaxial. But I agree with Dr. Pandey sir that I feel more comfortable personally with the bimanual, or you can use different coaxial cannulas like a J-tip or a bent tip coaxial cannulas for these kind of situations when the pupil goes small. So we would like to hear something more about the lens from Dr. Rajan.
Sir, you see, I have just dissected this fibers from using just a hydrodissection cannula.
Yeah.
Just, I think I have no need of using the PC polishing basically. Now I can aspirate it very easily by controlling my foot switch only.
ये जो गेट है आपका, ये पेशेंट वेटिंग एरिया में खुलता है.
I think Simco will also help you in this situation.
I have not used Simco since last 10 years, I do remember, ma'am. So I would like to, yes, I would like to implant the IOL. I will try to dislodge this cortical fibers. Note kar diya? Achha. I'll try to dislodge by IOL rotation. So
Another thing what you can do, Dr. Rajan, is just an advice that now you can have a bimanual as a help in such situations for subincisional cortex. I agree that you will require to make another port, but still that will save your time also.
Yes, sir.
And we
Yes,
agree
sir.
that
Yes, sir.
by lens can be used for mechanical dissection to dislodge this kind of lens material which is left over.
the beautiful lens material, you can see the easy delivery of this hydrophobic IOL. And you can see the holes and the toric marking on in front of the hole just to align with axis.
And sir, in situations like small pupil, fluffy iris, there also the bimanual irrigation is much beneficial.
So excellent surgery done by Dr. Rajan Gupta, a magnificent toric lens. Now we'll be shifting to the next case, and the next case is deferred live surgery from Johnson Johnson's, and it will be presented by Dr. Virendra Agrawal sir. And it's on. He is going to show us the use of Synergy IOL, a trifocal IOL from J&J.
Thank you, Mayank, for this opportunity and excellent show of the surgery. Then we are seeing the excellent surgery done by Rajan, meticulousness.
Sir, one thing I want to highlight as well. If you see any non-dilating pupil, the pupil dilates, goes down on the table. What I have come to Rajasthan, one thing, you can put the dialer like this and hold it and just lift the iris and go behind it, and you can see it very easily, and you can tilt the eyeball as well. So in Rajasthan, the gungat is very famous. So I always call it as a gungat technique. Just open this and see behind the iris.
Thank you, sir. Yeah, excellent way to show, and we can use button dialer for this situation.
Yes,
so
sir.
Now we are going to a deferred surgery because of the issues with the live surgery. Some companies are not agreeing to do a live surgery. So we have done the recording of the surgery, and we are going to discuss about the Synergy lens in this surgery. So we have made a small rhexis which is relatively 5 mm, and I am not going to discuss many of the things for the phaco part because you all are very good, excellent phaco surgeons. So what we are going to discuss is that what are the important things required. You need to take care that the endothelium should be prevented and should be clear the next day, because otherwise patient's expectation will not be met. I am going to do a routine phaco. You do chop and you remove these nucleus pieces. But I am going to come to the situations what I feel are important for multifocal or trifocal or premium lenses is that you should prevent PCO to the maximum. You should aspirate out all the cortex. My preferred technique, as I was discussing before also, is a bimanual irrigation aspiration. It gives me an extra tool to hold the eye, to control the things, and to do a cleaning all 360-degree. So with this, and I use the polishing on the both sides, the sandblasting cannulas for irrigation aspiration. So I can exchange them, I can use them wherever I need kind of sandblasting for removal of the cortex, and this way we can do it faster and fast. So the same way as I showed that we can exchange the hands and show, I use main pot also whenever required for cleaning of this. I take more time in polishing than doing actual phaco, because I feel personally that this reduces the PCO to the maximum possible, and I'm lucky that I'm not doing PCO almost to many of the patients, or almost like a nil in Technis platform IOLs, be it a monofocal or multifocal or a synergy lens. Nowadays, my first choice for any option is a synergy lens. I do it in all professions. I have done in doctors, I have done in bureaucrats, politicians, and anybody who is ready to accept that the rings will be visible. My counseling line is just one, that you will have some rings for crisper vision for distance and near. I agree with Dr. Khokar sir that once you feed something in mind, he will say yes, rings are there. But when I ask next time, do you have any problem? They say no. So that is the important thing. I have my own reservations, no financial reasons to say, but EDOF lenses have to still grow to come to the expectation of the patient. So we have to clean the visco all around, anterior and posterior to the IOL. We have to remove all the fibers, cortex, whatever is remaining. And at the end of the surgery, you have to tape the IOL in the center. The biggest reasons of using synergy is that it gives me a vision at the distance what patient wants. Initially, when I was using multifocal lenses, I started with the 4 diopter ad. As I said, the patient used to keep slightly nearer, or we have to keep them slightly hypermetropic. When the 3.25 ad came, it becomes very comfortable. But still, some of the patients who are having some issues of habits of keeping the things at a particular distance, they were annoyed or not very happy, because they were saying that you are fixing me to hold the book or near print at one particular distance. With the use of this continuous range of vision, after 33 centimeter, my life and patient life both are comfortable. I am using this lens at my first choice, and as we discussed before, not explanted any multifocal, not explanted any continuous range of vision. Hydro at the end should be that it should not be too tight AC with the overfilled. It should be a tight section sealing rather than overpressure sealing. So it should not decenter the IOL, it should not shift the IOL, and I prefer to keep one haptic on the temporal side between 8 to 9. Suppose I do a right eye, if I do left eye, the same way slightly inferior to the temporal incision, and I am happy with this. The glare and the dysphotopsia part is reduced. There are some papers who says that if you keep the optic here, it almost works like a extended optics. So by this, we can reduce that part. And as many people are afraid of that the patient will complain about the glare and will be after your life, it is almost not there. For almost 5 years, I am seeing that the patients are never ever complaining that the glare is an issue if they know it beforehand, because there is no free lunch. You get something on something. So if you want near vision, you need to bear with the rings, and within short period of time, they never complain for the glare. This is my take home message, and thank you for this opportunity again. Any questions? I am ready. Now we are going to have surgery from Dr. Piyush Kapoor, and he is going to show us an advanced monofocal lens Evolux from SIFI, marketed by Zydus. So over to Dr. Piyush Kapoor. Yeah. Sorry for keeping you waiting for a long.
Am I audible?
Yes.
Can somebody check that whether I am live or not? Am I audible?
Yes, sir.
A very good evening and thanks Rajasthan Ophthalmic Society for giving me this opportunity today. आज हम बहुत सारी बातें कर रहे हैं मल्टीफोकल सिनर्जी ये लेंस वो लेंस मैं आपसे अपना एक एक्सपीरियंस शेयर करना चाहूँगा जो बस कल ही मेरे साथ हुआ I had a lady operated grade 4 cataract, almost about 80 years of age, coming from Vrindavan, and she was deeply annoyed, though she had a vision of 6/6. तो बैठते ही मुझे कहती है कि डॉक्टर साहब पहले तो मैं फोन देख लेती थी लेकिन अब तो मेरे से फोन ही नहीं मिलता तो we generally talk about vision, we talk about lenses, we talk about everything, glare, halos. Then if we have the technology which can give us distance and near both, I would ask कि हम सब में multifocal क्यों नहीं डाल रहे? And the basic fact remains that come what may, any lens which may come up with rings, which may come up with abrasions or some kind of a change in the optics, as compared to the monofocal lens, the MTF or the modulation transfer, these is always compromised. They do saline डालिए cornea पे. They do have a compromise in the vision. Whether we create a central bump, whether we create abrasions, if we are giving us near vision, these lenses will always actually cause a visual disturbance which is different from patient to patient. Some may complain, some may not. So the basic thing what I want to convey is that now is the era of lenses which actually do not cause that much of a disturbance, of course, but at the same time help the patient to carry on the intermediate vision very well. So these are what we call as monofocal plus lenses. The monofocal is a new generation of monofocal lenses, a step advanced than monofocal. And I would actually say that in my practice, almost the entire monofocal has got shifted from monofocal to monofocal plus. The best thing with these lenses, of course, is that you actually get a very near vision, and such is a lens Evolux which I am going to implant today. This lens has got a central 4.5 mm zone which actually includes a negative and a positive abrasions, which is a very different concept as compared to the diffractive rings or when we talk about the refractive bumps and other things. And abrasion, of course, एक साइड पोर्ट और चाहिए और मेरे को विस्को दीजिए. They cause very, very minimal change in the distance vision. The MTF, when we call as the modulation transfer function or the light transmission through these lenses, is a bit compromised as compared to the monofocal, but that bit is way too less to be significantly visible. The new generation or the new era which has actually taken its shape and slowly it is actually evolving to replace the monofocal concept. The best thing actually say is that today all of us actually need a good distance vision and we need a good intermediate vision. अगर हम अभी लिया तो that actually does not affect us or we don't mind using it. कि normally light में देखिए don't mind using that plus or so, and the lens should be so forgiving that at least I would say 99% of the patients should not have any issues, which is one like we get in monofocal. So these are the new generation monofocal plus lenses, and Evolux, one of the very promising ones. I may have implanted a more than about 60 or 70 of them, and I would say 100% of the patients are very satisfied. इसको जरा पानी से वॉश कर दिए. They are happy because, एक मिनट मेरे को थोड़ा सा ना कैप्सूल पॉलिश करना है, ऐसा वो दे दीजिए मुझे इसको थोड़ा सा, और ये most of the patients they get a near correction that I would actually just recommend them to use a 1.25 or a 1.5 addition, and they are pretty happy and they are able to reach up to about N6. Something which we tend to miss out on these patients is that we do not analyze that how much are they actually able to see for near in an unaided way. So if you just bring the target of focus somewhere to about 45 of them, they can touch even to about an N6 with a binocular implant and a micro monovision concept, and most of them, or almost I would say 90-95%, touch up to about a N8. The next most important thing about monofocal plus lenses is the concept which any surgeon would desire and always want in his lens, that even a slightest variation in the biometry does not affect these as they would ever do for a monofocal. कि थोड़ा बहुत अगर 0.5 आगे पीछे हो भी जाता है, the patient's vision is not compromised. But at the same time, light में देखिए, if we talk about any of the multifocals or so-called even the real EDOF ones, which come with the central change in the optics design and other things, these entities of a little error in the biometry are unforgivable.
So Dr. Piyush, what is the difference you keep between the two eyes for micro monovision kind of thing? Or
sir, before I actually implant the second eye, I always check for the vision in the first eye.
Good.
Most of these patients I generally target somewhere about a 0.5, which is good enough.
In the first eye?
In the second eye.
Okay.
0.5 myopic in the second eye. And I generally, when I book the patient for the second eye, I always make them read. It is always that most of my optometrists would actually do that. They would, rather than doing a refraction, they would give me a unaided vision distance and near both, and at the same time then they would give me the refraction. Seeing what I have done in the first eye, I would actually modulate and put the par for the second eye.
So this is an important tip, that before doing the second eye, all premium lenses, you should know the refraction and refractive outcome of the first eye. That will help you.
Light में देखिए.
That will help you and save you for the surprises.
I would actually say that the technology has evolved so beautifully that we have, as eye surgeons, can actually give what our patients desire. It is we who need to understand that what the technology actually says, how the technology has to be used, and where and when it has to be modulated.
Yeah, you are very correct, and we can use these things for a particular requirement of the patient according to their lifestyle.
Most of the patients, if they get a N6 distance and up to about a N8 or even a N10 for near, I would say they are very happy. The second most important thing as surgeons which we have to understand is astigmatism. Like if a patient of mine has an astigmatism at 90 degrees, I am rather very happy and I do not go and correct it. If I leave a 0.5, 0.75 of astigmatism at 90, then and give a slight myopic, like say about the final refraction comes 0.5 or 0.75 at 90, most of these patients get a distance vision of 6.6 and they reach up to about N6 for near.
Yeah.
So these small tips.
Hello, Kapoor, Dr. Kapoor.
Yes, sir.
Astigmatism at 90. With the rule or against the rule?
Minus cylinder at 90.
Minus cylinder at 90.
Minus cylinder at 90, sir.
Minus cylinder. So against the rule.
It increases the depth of focus.
The steeper axis has to be 90.
Yeah.
Steeper axis to be 90. Okay.
Thank you, Piyush Kapoor, for showing us the excellent surgery.
Thanks, sir.
And now we are going to another surgery as a deferred surgery. I think it is ready. Dr. Vishal, are you ready there?
Yes.
Yes, so we can have it. And now, just after that, we will have Dr. Vikas Gupta, a very young, dynamic, fast surgeon, to show us a surgery live from OT, ASG OT. Yeah. So go ahead for deferred live.
Hello, very good afternoon. This is the second deferred live surgery from Johnson & Johnson using the Technis Advanced I-Han's Toric lens, and this surgery was done today afternoon at the OR of the ASG Eye Hospital. And I would like to thank Team ASG for the excellent setup. And I want to congratulate Team ROS, Dr. Vishal Agarwal for the fantastic show, Dr. Virendra Agarwal sir, entire Team ROS and entire Team ASG Eye Hospital. And this was a 39-year-old case and posterior subcapsular cataract. You can see the cataract surgery has been done, cataract has been removed, and we are implanting the Technis I-Han Toric lens using the Technis Simplicity delivery system. So you can see that I have done the rexis of approximately 5.25 millimeter in size, and this is the Technis Simplicity delivery system, which allow us to implant the lens without any touch. This is wonderful system, and you can see this is 15.5 diopter Technis I-Han Toric lens, and the Technis I-Han Toric lens is one of the very excellent lens which worked on the continuous high order spherical surface. And you can see there are 3 steps of the lens delivery using this system. First step is you have to use BSS or the IOL, and one should always keep the lens off 15-20 degree, and then once you remove the viscoelastic, then you can position the lens, align the lens at the axis. In this particular case, we made injection at 180 degree, and the lens alignment was done at 75 degree. So this is the removal of the viscoelastic being done, and you can see the pupil is coming down. But the advantage of the Technis Toric lens platform is that it contains 4 dots, so you can see the toric lens even in the small pupil also. And sometime once you do the surgery, then people may come down, and it happens in this case. And once I try to rotate the lens, I'm checking the lens by using the dialer, just trying to retract the iris and checking there's alignment. The lens is aligned at 75 degree, and this is the after checking the lens, you can use the Kuglen hook also. So once the lens is properly aligned, in this case it was 75 degree, then we can hydrate the incisions. And it's very important, as mentioned by previous surgeons also, not to overly hydrate the incision, and the pressure should be just ideal. It should not be too much pressurized eye, and not the shallow chamber. And in that way you can ensure, you can minimize the possibility of the IOL rotation. So the Technis I-Han Toric lens is one of the best lens available nowadays. It contains the refractive index of 1.47. The thickness of the lens is 0.46, and it has the protect design, and it has the frosted haptic, so it locks inside the capsular bag. There is less chances of the rotation. And in my experience, all patients I have done so far 10 cases, and they are the performance is just wonderful, with excellent distance and intermediate vision. And this is one of the new tool in the armamentarium of the cataract surgeon. Thank you very much for your kind attention. Thank you.
Thank you, Dr. Pandey, for showing us excellent points for the I-Han Toric and excellent surgery. This deferred surgery was just recorded before this session of the surgery itself, here in Jodhpur itself.
OT free हो गया?
Yes. So we are going to start the surgery.
You are not visible. You are not visible, only audible.
Dr. Vikas Gupta is the surgeon, so why I should be visible?
So
OT1 feed. OT1 feed.
Yeah. OT vision is not in the.
भैया OT feed चालू करो.
Table 1 feed चालू करो.
OT feed वापस चालू करो.
So Dr. Vikas Gupta, young dynamic surgeon from the Jaipur.
Sir, they are shifting the feed.
Wait, Viru.
Yeah. He is going to implant a lens which is Evolux from the Physiol BVI company.
Now it's visible.
This is again an advanced monofocal lens. Sorry. This surgery is on Isopure. The previous surgery was on Evolux. My mistake. This surgery is done on Isopure from Physiol BVI.
Am I audible?
Patient does not have a significant astigmatism. Only difference is between the two meridians is 0.25 diopter. So he is going to implant non-toric lens. Over to you, Vikas.
Good evening, everyone. I made 2 side ports and I put Visco and Phenocan. Now I'm doing Rexes.
इतने नाम आ गए याद रखना ही मुश्किल है मेरे को तो आजकल आता है ना वो पूछता हूँ कौन सी कंपनी का है
It's a soft cataract.
मिलते जुलते भी नाम हो गए ना ये लगाया तुमने आइसोप्योर सारा बेटी तो बिल्कुल ही फर्जी है बाहर हो जाएगा ये तो एल्कोन का इतना हल्ला है इसलिए चल रहा है नहीं तो अब तक बाहर हो जाता बंद हो जाता वो तो उनके फंस गया ना उन्होंने इतना हल्ला मचा लिया पैसा लगा दिया और उनके फिक्स जो यूज़र है ना जो बिल्कुल टाइड अप है विद द मशीन
पहले सिंपली आया था
हाँ सिंपली तो मैंने आते ही बंद कर दिया था मैंने फर्स्ट लगाया था और फर्स्ट आदमी ने कहा बंद कर दो इसको तो कंपनी बोलती क्या बोल रहे हो
वीरू सर आपका योर बाइक इज ऑन सो प्लीज
Mic is on and he's on. Doing hydro delineation and hydro resection also. The soft
what excellent Rex is done and hydro procedure done.
Yes, and this lens is soft. That's why he's tilt and tumble method he's using. I think.
Bolo.
So it's really important to do a very good dissection and delineation both in this case, and we can see that.
विकास जी कुछ आप भी बोलो.
Raji, you are not audible.
Yeah. Vikas, you need to be a bit
settings
loud.
is like for a
What is your plan? What you want? You are going to do in this case?
60 is IOP and it's a soft cataract. So I've kept my fluoride little lower side.
So Vikas prefer to use bent tip or straight tip in majority of the patients?
Sir, I used to prefer bent tip. This is balance tip.
Decentered, because it is decentered.
Sir?
Decentered, decentered.
Center. Okay.
Center करो उसका. Yes, yes.
Now it's
Okay,
centered.
okay.
I'm trying to do direct chop. It's a soft cataract.
So you see that he is doing central chop. Case is soft, still is going to do a direct chop kind of thing. That is a skill required for managing these patients with a chop.
In soft cataract, chopping is difficult, but if you get a first crack,
So in some patients, I many times prefer to do a multiple layer of hydrodelineations to separate out the nucleus and make it slightly more compact. So, because what is your advice and opinion for this? You have done excellent cracking in a soft case. That is a big thing.
I'm trying to eating in 4 quadrants because it's a soft one. There is no need to make it in 8 or very small pieces. It's a soft cataract. No.
You were discussing something about a balanced tip. Highlight about that.
In the meantime, I would like to
It's a soft epinucleus.
Meanwhile, you are seeing the surgery done. We will discuss something which we missed in the beginning. There was surgery to be done for Hoya Impress, again an advanced monofocal lens. Dr. Mayank Sharma, what is your opinion and experience with this lens?
So we have been just started few implants, and we are just seeing and reviewing the results. So far we have found promising results, but yeah, definitely not very good near vision, but yeah, functional kind of intermediate vision is there, and that's where all the companies are trying to emphasize on. Definitely good distance vision, no glares, no halos, but yeah, some and decent kind of intermediate vision is there. That's what we are trying to achieve.
What is your opinion, Dr. Mayank Agarwal, about this lens? I know that you are using a lot for this lens.
So first of all, this lens is on Vivinex platform, so it gives all the advantages of the Vivinex platform. It is not an EDOF, it's an advanced monofocal lens in which the central 2 mm area is being modified. An optical element with a smooth surface profile is added, which creates variation of power and gives the extended depth of focus. So your distance vision is not compromised, yet you get a functional intermediate vision. And in my experience, for the near ad, we are just using 1.5, maximum 1.75 for the near vision post-operative optical glasses. So till now, I have implanted few. The results are as per the company's expectations I am having. We are trying to avoid the against the rule patient. We are putting these lenses in patients who are having a cylinder of 0.75 or less. In higher order astigmatism, we are still avoiding it because in those cases, the results are unpredictable.
Thank you, Dr. Mayank Agarwal. And now we are going to have the Isopure to be implanted by Dr. Vikas Gupta. So now what we are seeing that the practice is shifting from routine monofocal to advanced monofocal, or from normal multifocality like a bifocal lenses to trifocal or continuous range of vision IOLs. And another field is the EDOF lenses. EDOF lenses and advanced monofocal have only bit difference that advanced monofocal lenses, they require almost around 1.5 diopter addition. Many of the EDOF lenses also require around 1 diopter of addition. But some of the EDOF lenses get better in some of the patients because they have some limitation to increase the aberration in the center. That's why the depth cannot be achieved in all, and it depends on the primary aberrations on the cornea. If they are add-on, then the spherical aberrations increases. But whenever the spherical aberrations increases, they may get good near vision in the sense of quantity, but the quality of vision will be a compromise. So you need to take care of a balance between different lenses, and here comes a role of different tools what we are using in preoperative workup, like a topography, aberrometry, the clarity of the cornea itself, and the health of the macula. So my advice and my workup is this, that I do these investigations for all patients. What is your opinion about this, Dr. Mayank Sharma?
Sir, completely agree with you. Yes, sir, please ask.
Viru, what is your opinion about VVT lens? That is the EDOF lens, VVT.
Yeah, I used lot of VVT lenses, but
What is your experience?
yeah, my experience is that very few only are happy to read something on a print, but they are happy for reading on mobile and laptop. But many of the patients in India, as far as I know, they want that something should be print happy. Means they want to read the print also, the newspaper also. So keeping the difference like micro monovision, then I feel the cost of VVT, no financial reasons to support or not support, is a big reason that when we increase the expectation of the patients, they expect something more. They can't understand the limitation of the lens. So now we are going to shift first to Vikas to have the loading of the Physiol Isopure. There is a special loading device with this. So it makes it like a no-touch loading. प्रेस करते जाओ करते जाओ. So there is a special device into it. The lens is loaded in the cartridge,
It's
and
not visible. It's not visible.
there is a issue of showing it on the microscope because it requires a depth which is much more than expected. So we are not showing that loading, but just for the benefit that we want to say that there is a loading device. It comes into like that it is a coming the lens delivery in the solution. You have to press that injector over that cartridge. You will hear a click sound, and after hearing a click sound, you inject the visco behind the lens and in the tunnel. Once the visco start dipping from the tunnel,
Yes, now it's visible.
so you can see that hole.
Dr. Vikas is injecting visco in it here.
So it has a rotational method, or it's a means.
No, sir, it's a push method.
Push. But that push is very guarded. There is a particular device attached to the plunger, so you can't over push. And after loading and implanting visco, then you have to start pushing the lens, and it comes very gradual, very soft delivery, and it can be done through a very small incision, 1.8 also. So that is the advantage. And again, it is from the family of the advanced monofocal lens from Physiol BVI. This lens was, the Physiol was introducing the trifocal lenses in the India for almost 7-8 years. But this monofocal lens has come now in India almost 2 years. Almost 2 years. So Mayank Agarwal,
pushing the lens.
what is your experience with this Isopure?
So my initial experience, I'm using this lens since last 6-7 months time. I implanted almost 25-30 lenses, and initial results are good. My patients are very comfortable for intermediate vision, and the add-on which we are giving in these patients is not more than 1.5 diopters. So these lenses have basically working on spherical aberrations on the anterior and posterior surface. The central 3 millimeter is being modified for aberrations, which gives a extended depth of focus, and the patient is not losing any amount of distance vision, no complaints of glares and halos. It works as good as a monofocal lens, and in addition it gives a functional near vision. So it's a 4-plate haptic design. Vikas, will you please center it a little? Yeah, that's good. It will gradually come down. It opens up into the AC and stay here. Yeah, and nearly 100% there is an in the bag implantation. See how beautifully it goes down there. You just tap the lens in the center, and it finds its place into the bag.
You are seeing a notch. You are seeing a notch on the right trailing haptic, and you'll see that this is the way you can actually know.
Very excellent surgery.
Excellent surgery,
very
excellent demonstration.
Excellent implantation, and very
And
youngest person. And
I
for
wa-
surgery, and his hand is very steady. It
So-
seems that he's seasoned player. It looks like he's a very seasoned player.
So he is a young by age and senior by experience. And he has shown an excellent rexis, which is a actual size we should prefer to do, because some reports are coming when you use smaller rexises, the chances of having IOL problems post surgery down the years is much more. And we are seeing the tsunami of the lenses which are being shifted from their place to the posterior chamber or getting displaced. So now we are shifting over to Dr. Lakshman Jala, the king of Udaipur, and a versatile surgeon. He is going to demonstrate us the machine and the lens. He is using
So as
Alcon
you see that
Centurion, and he is
the
fond of
patient-
using
yeah,
this
yeah, watch है कि वो
panoptic
है?
lens. So over to you, Dr. Lakshman Jala.
So patient was getting little restless, so I started my Rexis, and I am a coaxial surgeon. So I my Rexis and started the surgery as the patient is sitting right from the morning, getting restless. Quadrant पे, yeah. So you see that I am Am I audible?
Yes.
So as you see that I never use chopper, I use only Sinsky, and with that Sinsky I do all the procedures. And you see the beauty of this Centurion machine, that I am not using the second instrument with my hand. Left hand I am just holding the nucleus piece. You see the anterior stability, the heating. See, I have not used any second instrument in my left hand. There is no instrument in the anterior chamber.
So Lakshman, what you would like to speak about the panoptics or the machine?
So machine, as you see that excellent machine with active fluidics, post occlusion surge, the balance strip, everything is so comfortable that since I am an Alcon user since beginning, since many years, I like this machine very much. And the safety of surgery, as you have seen that with only my right hand I have completed all the pieces.
So Jala sir,
you see the
lens you are going to implant.
And I am going to implant the panoptic toric lens.
So tell us something about this panoptics.
So panoptic toric lens is a trifocal lens, hydrophobic, and
it has a center 4.5 millimeter.
100 to 150 lenses. On 2 patients complained of glare and halos. That too, they were confused and not very much. They have read on the Google that these produces glare and halos.
So as we all
See,
know,
and you can see that even the subincisional cortex with the small pupil, I am able to take it out.
So he has shown a very special way to remove the subincisional cortex by keeping the eye tip almost horizontal, not keeping it vertical. So to control the movement, the iris is not being caught and he can remove all the fibers. He is an excellent surgeon, so it is difficult to say that the machine helped him. Actually, he is helping the machine.
So you can see that
done.
surgery has been done.
So what you feel the panoptics is a special choice of yours?
Those who want to be spectacle free and they are fit for trifocal or this trifocal surgery, I would prefer in each and every patient. Those patients who are drivers or who are very much particular about the glare or halos, such patients should be avoided and EDOF lenses can be implanted. You see now.
Dr. Jhala is suffering from fever, but it is not reflecting on his hands and is showing excellent surgery. So we must congratulate and appreciate.
See now it has gone in the bag.
Surgery.
Excellent surgery. Excellent, Jala Sahab.
Thank you.
So how many rings this panoptics have? 15 rings or panoptics. So now we have from the 4 rings to 15 and 22 rings in different IOLs. So the way we are progressing, we are reducing the number of rings in different lenses.
Yeah.
And we are changing their configuration and the step height and step pattern. That is how we are reducing the glare and halos part. And I feel, because now enough number of patients are implanted with these kind of lenses, the patient's word of mouth is also convincing to the others to get these lenses.
नहीं हाइड्रोकन वो
So do you prefer to use intracameral antibiotic also in all patients
in all
or
patients.
selected patients?
In all patients, it is a routine.
So that is also a kind of thing.
So you are using Vigamox.
Yeah, intracameral moxifloxacin.
So intracameral moxifloxacin, particularly for the volume surgeons and volume
Yeah.
centers, is a big savior. Though it is not only because of that Megamox,
moxi.
it is because of surgical skill,
Yeah.
wound closure, the proper hydration.
And as you see that I never used chopper in my life. I have done around 30 to 40,000 phaco surgeries. Only Sinsky is my instrument and Utata forceps. I require only these two forceps to complete my surgery with any grade of cataract.
So cataracts are so fearful with the king jhala, they get chopped out with
Thank
that
you.
soft cataracts. Yeah, but I agree with him 100% that chopper is very rarely required in cataracts. I know sometimes you actually get brown black cataracts, you may require chopper, but it's more of a technique. You can use other dialers or Sinsky
बहुत बढ़िया वीडियो
also.
आपके
So
हाँ.
we are going to have another surgery
₹1,00,000 वो
from the
काम
host surgeon, excellent surgeon, Dr. Mayank Sharma. He is going to demonstrate us another kind of advanced monofocal lens from biotech. So before he is getting ready, I will ask him.
That's what we have been talking about so far. Not very good or very excellent near vision, what a patient would expect. But yeah, saying it an advanced monofocal is the right way of counseling the patient. What they claim and what the design of the IOL is that it's a pupil independent IOL in all conditions, because it is giving separated zones of intermediate as well as distance vision together in their rings. So that design will share with you. And it's a natural IOL and it's a preloaded IOL, and they say up to 1.75 plus 1.75 extended depth is there on spectacle plane. So simply it means it will give close to 1.5 or 1.25 addition for near at least. Yeah, so let's see how it goes. I'm going to start it.
So he's going to us the surgery, and meanwhile we prepare the next case on the next table. So we are getting a feed, micro feed of Dr. Mayank Sharma. He is a volume surgeon, very cool, calm person, and I am seeing his organizational capabilities of organizing the things with total peaceful mind, smiling face, and for everything he said, yes, it will be done. We came yesterday, we asked for many things in OT and it was done in no time. Everything was done very smoothly. I am really very happy with him.
थोड़ा सा लाइट के बीच में बस वेरी गुड परफेक्ट अब हिलाना नहीं है.
So we are having the host surgeons. We have taken care of the guest surgeons. Now this surgery is being done by Mayank Sharma. Next is by Dr. Mahendra Paliwal. And then again there will be a talk by Dr. Mayank Sharma.
Relax रहे सर.
So do you prefer to use air bubble for these dyes? Because there are many surgeons who prefer some viscoelastic and they do visco paint under the viscoelastic. I personally feel air is a useful tool. Dr. Piyush Kapoor, what is your opinion?
I didn't get your question properly. You mean for
You want to inject air or no?
Okay. No, of course, air I feel is very essential, because if we don't inject air, there are chances of endothelial staining also. So air comes as an interface which actually prevents the corneal staining, and it becomes very essential that the cornea remains clear before the surgery. So I believe, in my concept, I always prefer using a air interface.
So he has done an excellent praxis.
Slide this karo, below
about concept about monofocal, like
Yeah, I can repeat that. लाइट के बीच में लाइट so mic ले So I am going to perform surgery on Sophie phaco machine. What they have given is a bent tip. The technique.
Dr. Virender, I'll just like to ask you, like we are talking so much about monofocal plus multifocals and all, how much percentage in your practice are you still using monofocal lenses, and what percentage has actually shifted to monofocal plus or the EDOF ones?
I think it is a very good question, and the need of the time that we are shifting ourselves also. Patient also demand that they want something better than monofocal, and financially also it is rewarding for everyone, because the need for glasses, if you can reduce a bit, the patients becomes more happy. There are many patients who says that at least for some of the time I don't require to use glasses, so I can choose the glasses which I do near vision at home. For that I will not require a very costly progressive, and the type of progressive we know are having a lot of cost constraints. I still use maximum as a I-Han lens, because I feel that it gives a very crystal clear, predictable, and every time repeatable result. Though I use almost all other monofocals also, but number are low, so I'll not say negative about them, but I-Hans gives me a consistency and confidence. But gradually these lenses may prove to be something better. The another thing is that the night vision and distance vision, I feel is definitely much more better with the I-Hans, because it is almost the similar platform, but some changes from the Technis platform, which is a very good lens for distance vision. The other lenses which are increasing the aberrations, and I have my reservations that when you increase the aberrations, if they fit in with the cornea well, and if the lens is very centered, then these aberrations will increase the depth of focus, will not compromise much of the distant vision, but otherwise they will have some compromise.
Virendra,
So, yes sir.
You have any experience? You are using pseudo monofocal monovision, micro monovision type of thing in monofocal lenses?
Yeah.
Some minus power in the non-dominant eye type of things. You are doing it.
Yeah, actually we don't have much of the choice to choose like a dominant and non-dominant eye in majority of the cataract patients, because if the cataract is very equal, then you can check and you can decide that this lens should go in this, means near dominant for the non-dominant eye and the distant dominant for the distance eye, because the patient wants one eye surgery only. Many times he is not ready for the second eye immediately. But if the choice is given, yeah, definitely it can be done. But what I do is that those who are not very keen to have a distance 6/6 vision, in the first eye itself, I try to keep minus 0.5, and that gives almost 6/9 vision in majority of the patients. And if he is happy with that distance vision, then if you just add on 0.25 or 0.5 myopia in the other eye, it gives a better depth of focus than keeping one eye emetropia 6/6 and just adding on the 0.5 myopia in the other eye. So what is your opinion about this, Piyush? And just meanwhile, after this question, we will discuss something about the new machine which Mayank is using, that is a Sophie.
Sir, I would say that the future still remains that when we will be able to get the exact measurement of the individual's corneal abrasions, because that will be the day when we will be able to actually match and give the lenses according to the corneal abrasions rather than just simply calculating the IOL power. You actually, if evaluate, there must be many patients in whom, if we are implanting the abrasion based lenses, they are very happy and some may not be. which have been a common concept with most of the EDOF lenses. And these are the patients who actually vary in their corneal abrasions, and those abrasions, if are getting neutralized with the IOL, they get excellent vision. And if at all it is an add-on with the IOL, they are the unhappy lots. So I believe as the advancements are going, the day is not far when we will be able to exactly measure the corneal abrasions, and we would be able to match and give the IOL not only in terms of the IOL power but also in terms of abrasion. And this is how the day is not far when presbyopia will be the treatment rather than cataract.
Thank you, Piyush. Now I want to hear something about the machine Sophie from Dr. Mayank Sharma.
So everyone could see, the case was done quite beautifully.
Yeah, I was seeing it.
Yeah,
It was very
so
smooth.
It was very smooth.
Yeah.
It's what they say is that they have a cutting of phaco just like a knife. So the technique which has been defined by Sophie is, they call it sinusoidal technique.
So we have seen again an excellent surgeon using an excellent machine and showing a very smooth surgery. There was no surge, excellent cutting, and now we are going to have an implantation of an advanced monofocal from the biotech. There is an acryl cert lens.
So
this lens is again preloaded. Yeah, bolo. Mayank, aap bolo.
Yes, sir. So this is a biotech IOL. It has a preloaded one, and what we have to do is initially we just have to keep this plunger up to this mark. Now what I've done is I've just injected the visco. So beneath this plate, by the first step, by injecting the plunger, we could make this come up to the mark. And now I have put visco beneath this plate, which is above the IOL. So this ensures the right orientation and loading of the IOL. A little bit of visco from front, and now we have to close it. So we have to close it till the click sound is there, and now gently I'm going to push this plunger again, and now we can listen to the mark, and now we can see listen to the So this was the loading for the biotech IOL Isopure, and now I'll be injecting it.
Yes, sir. Yes, sir.
Any experience with light?
ये टच नहीं हुआ ना, इंजेक्ट कर दो, ग्लव चेंज कर दो. So now we are going to see the loading is done, and he is implanting advanced monofocal lens from biotech. We are very happy to use biotech lenses. They are very good quality lenses, and they have come out with the concept of having this advanced monofocal from the Indian side. The other companies also have come out, but I have used these lenses and happy. He is not managing right now because he got a touch on his gloves with the unsterile person. So he is changing the gloves. So what you are seeing in the eye, he is not doing anything because he is changing the gloves. So just bear with, but it's not touching the cornea as far as I think, because AC is very well maintained.
Dr. Virender, any experience with light adjustable lenses?
Yeah, it is just theory. I have not used it. I was very much interested and thinking and looking for it. But I think right now it is still under only investigations. The few implant have been done, but because of the limitations, there are two particular things that you have to adjust the lens after implantation, and that implantation adjustment is available for a very short period. It is, and once done, it cannot be changed. So that is how much I know only about this light adjustable lenses. They were looking very promising almost 10 years ago, but still they are not seeing the commercial market. So probably there are issues, so it cannot be done. So this advanced monofocal lens, Mayank is going to speak about it. You can see these rings, but the patient does not feel them like a diffractive lens rings. So Mayank.
Yes, sir. So this is what I was trying to describe earlier, that there are multiple zones. They have created one in the center, then there is a zone for distance vision, and then again a zone for intermediate vision. And what they have done is that with giving these different zones alternatively, they have given a scope for having intermediate vision even in scotopic condition. So the rings are visible, and the outer ring, which we can see is an interrupted one, which has alternate fields for intermediate as well as distance. So these are rings, 3 rings alternatively, and they are covering almost 60 degree of vision. So even in scotopic conditions, they claim that it is going to give a good intermediate vision to the patient, and that won't be disrupted.
So what you will see that all the volume surgeons use coaxial to save time, and the people like me who want to give more time in the OT, they use bimanual. So over to Dr. Mahendra Paliwal, the organizing secretary of this conference, very fitness freak and cool person. So over to you, Dr. Mahendra Paliwal. You can start speaking.
Noxy.
He is going to use Alcon Centurion machine, and again a lens from the Alcon. His mic is getting ready. He is going to show us what people were asking in between Clarion VVT lens. So now the Alcon is having 2 platforms. One is a So there was a one IQ platform which was blue absorbing, and now they have changed something into that absorption light spectrum and come out with the concept of Clarion lens, which is glistening free. It is absorbing less number of light, and as Mayank Sharma was saying that this is a natural lens. So Biotech ICRILSAT was also a natural lens in which there is some blue blocking, but not to the level that the patient feel it like this. And lens is not looking yellow. The Alcon lenses were looking yellow. With the Clarion and the natural lens concept, the now lenses are not looking yellow.
Yeah, I completely agree, sir. And this is a new platform which Alcon has come up with for panoptics as well as VVT. So what we saw was a Clarion, and now it's again a Clarion. Yes, sir.
Start karo? Yeah.
So Dr. Paliwal is there with us. We are just adding his speak.
Good evening, everybody.
Yes. He's going to start his case now.
Am I audible?
Yes, sir.
Am I audible in the hall?
Yeah, Paliwal boss. Yes.
Okay.
So this one is a Clarion VVT.
Sandel साहब की आवाज आ गई.
Yes, boss. Yes.
It's giving extended
I am
vision.
making the side port
It's a hydrophobic IOL.
with the MVR blade. I also use bimanual IA and coaxial both. क्या चीज़ है ये? डाई की जरूरत नहीं है. इसको इंट्रा कैमरल को डाला इंट्रा कैमरल. I am putting intracameral phenocaine to anesthetize the eye.
सिंह भी सर से करा देंगे तो मैं बात करता हूँ उनसे.
Red glow is very good.
मैं ही करूँगा जो
So
करेगा, चिंता मत कर.
I will not use any staining. Entry. Main incision would be made by 2.4 kratom. इसको center कर दो. Center. Make it center.
It is not centered.
Yes.
Getting centered, sir.
Previously it was centered.
Yeah. Now again it
No,
is
it is
getting-
not.
Yes.
Yeah, now it's centered.
Centered, sir?
Yeah.
Okay.
Now I'll be making there is a guiding mark with this blade.
So you are trying to make the biplanar incision.
Yes. Now I am entering in the antechamber.
Yeah.
Basically, it's a triplanar.
Triplanar. Yeah, it is more safer than biplanar.
Now I'll be making the rexis. I make the rexis in clockwise manner. Most surgeons do rexis in anti-clockwise manner. Dr. Virendra is also doing, if I am not wrong, clockwise rexis. Grade of nucleus is probably less than 2. Rexis is completed.
Very good capsular rexis.
Thank you so much, sir. Now I'll be doing hydrodissection.
So he's doing a slow hydro dissection,
Yes.
but you can see a good wave has
Good wave
passed
rexis. Yes.
across the lens.
Now I'm decompressing from the other side. So we have seen clearly fluid is coming from this
Yeah,
side.
excellent demonstration of how the fluid gone and how to relieve the fluid from the behind. So are you going to do a hydrodelineation also?
No, no.
Okay,
no,
so what are the conditions in which you do hydrodelineation?
I do hydrodelineation only in PPC, posterior polar cataract.
Okay. So there is
Even-
an important tip. Whenever there is a posterior polar cataract, you want to separate the nucleus from the rest of the part
No.
and use that as a support bag and safety zone.
So I'll be using Sinsky. I'm also not user of sharp chopper. थोड़ा बड़ा मिलेगा चलो.
So you prefer a bent tip or straight tip?
It's a balance tip. Basically, it's a straight tip with a hump. So it looks like a bend. See, this is the hump.
Yeah.
So it is straight. There is hump. Then again it gets straight.
So it is
basically
like a
straight.
coaxiality wise straight,
Straight, yes.
but works like a bent.
Bend, yes.
So you prefer a 15 degree, 30 degree, 0 degree?
It only comes, I think, as far as my knowledge goes, only comes with a 45 degree.
Okay.
All the
So you
tips.
see, when you increase the angulation like 45, you get a more surface area where you can impale the nucleus and it becomes faster.
Chopping is better with
Yeah.
a 45 degree.
So it is just like a Kalman type of thing. Kalman.
No,
yeah,
it's not
a
Kalman.
modification of Kalman in which the Kalman was having a bend from the tip. What they have done is that they have created a hump. So if you see like a straightness, the tip is almost like a straight, but because it is first goes up and then comes down, it looks like and works like a Kalman tip.
I
But
prefer.
the advantage is that it doesn't get clogged so easily as the Kalman was getting. Yeah.
So I prefer doing rotation in bimanual manner. This with the right hand and left hand both works.
So, Dr. Paliwal,
Yes, sir.
you have done clockwise and anti-clockwise rotation.
Yes. Yes.
So he's checking for a free flow and free rotation of the nucleus. So wherever you want to do any manipulation, it should not be a restriction.
Yeah, that's very good tip because once you do rotate clockwise and anti-clockwise, it also clean the lens epithelial cells on the capsular equator.
So it minimizes the chances of PCO formation, and also it also help to remove the lesion of the cortical tissue as well.
So just for the benefit, I would like to speak about the parameters he is kept on. The IOP is 48, vacuum is 400, aspiration flow rate is up to 26, and longitudinal phaco is around 30, and torsional is what is setting 60. So 60% is a torsional. Yeah, and this soft cataract is able to chop by keeping the phaco tip stationary at a center.
Yes.
And using a soft dialer, so you are not cheese wiring the soft nucleus also.
It's
There is a
always-
good demonstration of a surgical skill.
So it's a Dr. Vinder sir rightly said. So right hand, the tip should be stationary, and only left hand should work. See, so only left hand should move. It should move only this.
Yeah.
And it gets
So
chopped
using
very.
a lateral separation after creating a crack.
So I would like to thank Dr. Mayank for giving me very easy case.
These soft cataracts seems easy, but they are not easy.
Yeah, so
very easy.
Mayank has really commented nice that you have made it easy. It was not that easy.
Nah, it's your technique that is very.
Yeah.
Looks like it's very easy case.
Because hydrodissection and the rotation of the nucleus made difference. to
And
help.
this is the beauty of Centurion machine, that I have removed the Sinsky, and in the last.
So it is a good fluidics.
Fluidics.
The piece is coming to the tip and is demonstrating it very well. So all time you don't require the two things inside. So tell us something about the panoptics.
Cortex.
Is it your first choice, or you have selective people only to whom you are implanting this panoptics lens or VVT lens?
Sorry, sir, I could
You
not.
are, as a first choice, you are putting VVT or panoptics.
If patient is not driver and halos are not a problem for him, definitely would like to use panoptics.
Okay, so why I'm asking this question is that usually the surgeons are limited experience with the one particular company or two particular company. This company is having both lenses, the EDOF lens also, and
Putting visco before taking
lens
out.
of a diffractive platform also. This is a good demonstration that before taking out the irrigation aspiration, you can inject visco to maintain the chamber stability. The movement of capsule fluctuation should not happen. Particularly very useful in high myopes.
I will use now coaxial IA.
So Dr.
For the
Paliwal,
first-
what is the usual IOP setting you try to keep? Because 48 I feel is slightly higher.
40 is the usual
Yeah, because in the
condition
rest of
for
the
me.
machines I am using, I am keeping a bottle height of 50, which is almost around 30-35 IOP conversion. So this machine, which is having a specialty of keeping the IOP control in the chamber, I think you should start shifting gradually to the 30 or
Yes,
less than
yes.
30.
I am planning
That
to
will be
shift.
more healthier for particularly glaucoma patients, high myopic patients.
Definitely, I would like to shift towards lower IOP. But right now, most of my cases are under 40 for the 40 IOP. Coaxial IA has the advantage of very stable anterior chamber and fast removal of the cortex.
So you prefer to use that bent tip of a coaxial IA or always use straight
From
coaxial
since
IA?
beginning, I am using straight tip,
Okay.
so I am comfortable with the straight tip.
No, whenever the pupil gets small or the rexis is smaller.
Then I would like to use bimanual.
Okay. Okay.
I use both the IA system.
So that is another thing that surgeon should not have any ego to say that I don't use this or I use only this.
Cap
It is good to use
polishing.
everything whenever and whatever is required.
Polish. Now I would be implanting VVT lens. This is recent lens from the recent addition from the Alcon. It's a EDOF kind of lens. only lens which changes the wavefront, and the platform is Clarion. Previously lenses were on Acrisoft platform. Now Panoptics and Clarion and VVT, they are on Clarion platform with no glistening, very soft lens, very clear lens. With this hydro, I am removing the small fibers which are lying on the posterior capsule, and this is very effective way of removing them.
This lens has a central beam shaped which shift the and stretch and shift the focus.
There are very small fibers lying over the posterior capsule, so I would like to remove with a jet of fluid. It's very effective. See, fibers are visible.
Yeah.
Hydro fluid. I would like to inject lens. Hydro implantation is my preferred choice.
So this is another point, that majority of the people who do hydro implantation, they do it for initially hydrophilic lenses, but this can be used for hydrophobic lenses also. And I started this almost in 2002, but then later on give up because I was finding difficulty for hydrophobic lenses. Hydrophilic lenses, it was good, but there are few people who are taken it further and doing it for every IOL.
I'm slightly enlarging the incision, main wound, vein incision.
So how much you want for this VVT?
Loaded.
Dr. Paliwal, you have increased this incision size for
As I said,
hydroimplantation?
Yes, I would.
Otherwise you do for all?
All. I do hydroimplantation in all of my cases.
Okay. So what are the things you are speaking about in favor of hydroimplantation?
Visco is, we do not use visco. So remnant of visco is not there. So post-operative rise of intraocular pressure is out of question.
Thank you. Hello.
And it's a good technique for toric lenses. So only thing which we should keep in mind is the unfolding should be very slow. Otherwise it flips and then it's very difficult to rotate in the bag. So second no aspiration. Now lens is in the bag, half portion leading active. बढ़ा दे तो कुछ और है क्या? और है क्या? कोई नॉट थोड़ा बढ़ा देते हैं. कोई और है क्या? Aspiration
surgery, and now we are going to have again a versatile surgeon, person and speaker, Dr. Mayank Sharma, to speak on EDOF, the quality and functional vision with no compromise. We are going to hear from him. Over to Dr. Mayank Sharma.
Thank you, sir. Thank you all for giving me this opportunity. And I would like to thank, first of all, IUC Care Group for giving me this talk on EDOF lens. Exactly the discussion what we are going through is whether it's an EDOF or advanced monofocal, and what the company is trying to name it is as a monofocal EDOF lens. So what they are trying to focus now, it's the technique which is being called as like inducing spherical aberration and kind of extending depth along with monofocality we'll see in the coming slides what they are trying to do. What exactly the technique is, basically a very small aperture is created, and one zone is being created in the center and second is in the periphery. So what we require is a negative spherical aberration in the center, which will give us a near ad, and exactly opposite to it is a positive spherical aberration which is induced, and that gives a peripheral near ad to us. So there is a various definition. What they call is actually it's a extended depth of focus IUL, and it is giving an extra point, and that definitely there is a smoothness in the curve in the depth extension and the focus. The graph will be seeing shortly. So more than or close to 0.5 diopter plus 0.5 diopter greater than monofocal control, and along with monofocality, if we are able to give some extended depth of vision and some intermediate vision addition, we are giving to improve the functionality in the current scenario. So this is what is a comparison and how we have to plan a lens. There might be more and more demand of patients who are coming to us and they are asking to us for giving them specs free life, but definitely we can't implant trifocal lenses or multifocal lenses in all the cases. So, and there are few cases and few scenario and few profile of the patient where we can think of this advanced monofocal or a monofocal EDOF lens. So reduced halo and glare and double vision, reduced optical side effects are there. That's what we claim. But yeah, definitely if we select right cases for trifocal and multifocal lenses, the gradual decrease and in the halo and glare and the adaptation, the neuroadaptation happens, and definitely those patients also get happier. So, but there might be few cases where we don't want rings, we don't want multifocality or trifocal implants, particularly where we feel the profile of the patient is particularly more of a driving or more of a very active person. So there we can think of these advanced monofocal lenses, and the more and more increase demand and utility is going to happen nowadays, because more of the digital work, more of the use of mobiles rather than reading, and more of the use of systems. So at least a functional intermediate vision, that's what I call always. It's not exact intermediate vision, but a functional kind of intermediate vision if it gives. So they will be more free of these dependence on the specs. So this is the design. Diffractive and refractive designs are there, which all the companies have given to us, and that's what is a comparison of all the known monofocal lenses and EDOF lenses. So there is a small aperture optics in this IUL. There's a mini ring, the pinhole effect in the center, and that the spherical aberration gives us a negative spherical aberration in the center, which will give us a near ad. So there is an area of elongated focus that is called EDOF, and Symphony earlier tried it in the J&J company. So this is a comparison with Zeiss, Symphony, EDOF lenses, and now IOC has come up with inducing the spherical aberration and giving us more and more of better EDOF function, more mono EDOF, what they call it. So this is a comparison how a myopic blur is reduced with spherical aberration. Without spherical aberration, the chart is upwards, and now in the inducing spherical aberration, we can get a better near vision. But yeah, exactly, not near, it's a intermediate vision. So using spherical aberration for EDOF lenses, a monofocal EDOF IUL. So this was the chart I was talking about in the earlier slides. So in a monofocal IUL, we are having a one focus that is mainly for far, and sometimes we can use it for near if we use a monovision technique. In the multifocal or trifocal lenses, there are three focus, different, separate for far, intermediate, near. And the EDOF lenses, definitely there were two foci. A lesser was what was less was this focus for near, which was less than the trifocal lens. And now this monofocal EDOF lens, they try to say that there is only one focus and the depth of focus is increased. So somewhere what is the newer IOLs or modern IOLs are trying for is a continuous range of vision is being tried to be given. So this is what is a comparison in the Technis lenses, monofocal and IN's lens, then the VBT IOL. So what IOC has tried to compare all the lenses, and now they are saying that this is a search for ideal IOL, a monofocal with some extended depth, and that they call as a no headache IOL. So the time will definitely prove it whether it comes with that or no. That is the basically target why they have come up with the lens, and they are saying there is a ultra high depth of focus, and all the surgeons are requested to share their views and ideas, how they feel and how they experience the outcomes and reviews from the patients. So this is what is the comparison 2020 and 2030 vision. Minus 0.75 if we induce, and particularly if we give for try to give some vision to patient for near. So this is what happens to distance vision, and this is what is being claimed with magnificent IOL, that it doesn't induce such kind of blurring of the vision for distance. So that's what they say. It's a monofocal EDOF lens, and at least the monofocality, the distance vision remains good enough. That is not compromised. But as we discussed, all of the experts were saying. First point was made by, I feel, in the morning by Dr. Mukesh Sharma, then Virendra Agarwal sir, and Mayank Agarwal sir, and everyone, and Dr. Ashul also. Everyone was sharing their views. All the eminent surgeons, they shared their views. That we are yet to come up with our experience with the advanced monofocal lenses, with the conventional monofocal lenses comparison, particularly for the distance vision. So this is what they are comparing: improved intermediate vision, giving intermediate vision up to plus 1.5 and maybe around 55 to 60 centimeter of the near vision. That's what is being claimed, and let's see over the time how it comes. And we all definitely agree with all the slides and all the targets that are being kept in mind by the IOC company and other companies which are coming with the advanced monofocal lenses. But we just have to see, so whether we agree with that or not. But yeah, we are trying it, and so far we have decent results. And we had this live surgery also on magnificent toric lens by Dr. Rajan Gupta, and that's end. And I would like to give my thanks to all of us, first of all to patiently listening to us for this talk on monofocal EDOF. And now from my side, I would like to thank all our live surgeons who performed our surgeries and very beautifully managed. Thanks to this group from Ikigami, they helped us in the live telecast. Thanks to Mr. Grover for such a beautiful telecast, and thanks to all audience, and definitely my very respected and my very close person who is standing with me till now. It's our very own Dr. Virendra Agarwal sir. Thanks a lot. Have a nice day. Looking forward to inauguration. Let's all join to us at Hall A. Thank you.
Thank you, Mayank, for doing it very excellently. And I must thank the audiovisual from the Grover, the Ikegami camera, the Zeiss people, the Alcon people, Sophie people, and all the companies who got their lenses implanted. It was a good show, excellent show, no complications, no problem, and excellent tips shared by a variety of surgeons. We had a host surgeons, we have a guest surgeons. So I think we are ready to shift from here and meet you in the inauguration. Thank you all, and I must thank the team ASG for full cooperation with enthusiasm and doing it excellently. Thank you very much.
Virendra sir.
Thank you, sir. Sir.
We
Yes.
are also thankful for this timely completing of this all third series, and audiences are very thankful to you all surgeons and Virendra sir. And
No,
ASG
this
sir.
all because of the team of the ASG people who did it very smoothly,
Yes.
without any speaking any negative, any time saying that sir ऐसे कैसे होगा, या without any time saying कि sir ये क्या कह दिया आपने, क्या कर दिया. They are very very cooperative, very cooperative.
Okay, sir. Thank you, sir.
Thank you, thank you everyone in the auditorium.
Looking forward to meet everyone at auditorium. Thank you. Let's meet and join everyone for inauguration. Thank you.
Dr. Mayank,
Yes, sir.
I must congratulate you. I think this is one of the best organized live surgery sessions we have seen. 13 surgeries uninterrupted and in very quick time. Really excellent. Very well done.
Thank you so much.
16 surgeries and I request from the MIGS side that everybody should come in time so we can have a good inauguration function and followed by a good cultural evening.
Looking forward. We worked really hard throughout the day. Now let's have some fun and we'll party hard. Yeah. Thank you.
Yeah.
Let's meet.
Chalo.
Thank you so much.